I'll start with the delegates. Like, introduce yourself. Where are you from? What do you do? What are your hobbies? And what is your prior experience? Okay.
Hi, my name is Tarang Bora, and I'm an ex-pediatric neurosurgery fellow from AIIMS, and I'm practicing as a dedicated pediatric neurosurgeon at Apollo Hospital in Jubilee Hills in Hyderabad. It's been 3 years since I am in private practice. I have just started doing more brachial plexus explorations for birth-related brachial plexus injuries. And the intention for coming for this workshop is to increase my knowledge and learn from the masters about what else we can do. Thank you.
Myself, Dr. Rajesh Krishna. I am a consultant neurosurgeon at Maitra Hospital, Calicut, Kerala. My previous peripheral nerve experience is that I had done a fellowship in the same, but recently I have not been operating many peripheral nerve for at least for the past 2 years. So I came to the workshop mainly to brush up my anatomy and to start doing some of the peripheral nerve again.
Hello, good morning everyone. My name is Rakshish Shetty. I'm a neurosurgeon in Mangalore. It's been a long time since I performed a brachial plexus surgery. So I want to refresh my anatomy and learn from the best in the field. So that's why I'm here. Thank you so much.
Good morning, everyone. I am Dr. Sriraj. I work at Dr. Mopan's Medical College, Wayanad, Kerala. It has been only 6 months I have to practice. I have no previous experience of peripheral nerve surgery. So this is just a starting like that I have come here.
I'm Dr. Aditya, working in E-Road, recently passed out 6 months back. Similar to him, same starting.
Hello everyone, I am Dr. Arun Kumar from Ranchi. I have been practicing neurosurgery for last 5 years, but never came across with the brachial plexus injury or any surgery. I came to learn here. Thank you.
Hello, good morning. I am Dr. Srikant Kumar Swai. I am consultant in IMS Hospital, Bhubaneswar. I have very little experience in about brachial plexus injury. I came here to learn and to start practicing. Thank you.
My name is Dr. Bhanu Teja. I am a senior resident from GB Pant Neurosurgery.
Myself, Sajal Gupta. I am a senior resident in GB Pant Hospital.
Good morning, dear doctors. I'm Dr. Balasubramanian from Neuro Foundation Hospital, Salem. Basically, I'm a plastic surgeon. I retired from Indian Army in 2020 and pursued my MCH plastic surgery from Banaras Hindu University. And since my early days in Army, I had an inclination towards peripheral nerve surgery, but this is a good forum where I can upgrade my skills. Hoping for the best. Thank you.
Good morning all. I am Dr. Chandrasekhar Reddy. I am from Andhra Pradesh. I am working as assistant professor in Rangaraya Medical College, Kakinada. And I don't have any previous experience with peripheral nerve surgery. This is my first time. Thank you.
I'm Dr. Sudarshan Agarwal. I'm from Tirupati, SV Government Medical College, assistant professor. I don't have any experience of brachial plexus, so I wish to learn, sir. Thank you.
Good morning all. I am Dr. Krishna Mohan, consultant neurosurgeon at KIMS, Nellore. I've been practicing for the past 7 years, but I didn't operate any case of brachial plexus, even though if they are presented to me. So with this knowledge, I try to inculcate this into my practice. Thank you.
Myself, Dr. Subham. I have completed MCS this year and I am doing my bond period in Government Stanley Medical College as assistant professor. Thank you. I have less experience in peripheral nerve surgeries.
Hello, I am Dr. Sunil Kumar Das. Currently, I am practicing as a consultant neurosurgeon in Kolkata from past 2 years.
Good morning, I am Dr. Priya. I am currently a senior resident at AIIMS.
Good morning. I am Dr. Sarvesh, currently Chief Resident at AIIMS.
Hello. Hello. Check.
Good morning, I'm Dr. Navneek. I'm
Hello,
Senior
check,
Resident
check.
at AIIMS.
Good morning. I'm Abhishek, currently SR at AIIMS.
So thank you for the introductions. I am Dr. Deepak Agarwal. I am a professor at Neurosurgery at AIIMS, and we do a lot of brachial plexus here in the trauma center. With me, we have Dr. Praveen Bharadwaj. He's a plastic surgeon at Ganga Hospital and an expert in brachial nerve surgery. He can talk a little bit about himself.
Sir, and good morning, everyone. I am Praveen Bharadwaj. I come from Ganga Hospital in Coimbatore. Actually, I am a resident of Delhi, but after finishing my 12th class, I never came back to Delhi. So I have done all my studies in South and then settled in Ganga Hospital at Coimbatore. I am orthopedic surgeon to start with. Then I got training in hand and microsurgery and working in plastic surgery department. So in Ganga Hospital, the hand surgery is done by the plastic surgery. So I'm into the plastic surgery department. Even most of the people think that I am plastic surgeons, but to start with, I was orthopedics. But in present days, in our practice, I think 90% of our practice is brachial plexus. About 70% of it birth palsy and 20% of it around adult palsy. There are 4 consultants who do brachial plexus in our hospital, and we have quite a good load there. And I think with whatever I know, we'll be able to help everyone. Thank you.
Thank you, Dr. Praveen. I think he is one of the very experienced, I would say, surgeons in this field. So we'll all definitely gain from his knowledge base and skill set. And we'll start immediately. What I just want to tell, we'll have 4 people per cadaver. That means 2 on each arm or each limb. And we'll have one of our residents with you just to help you around, assist you. And we have the labels and everything already decided for which cadaver, which limb, which person will be there. So we welcome you for this course, and we want a good hands-on later on. So we'll quickly finish the theory classes, the inauguration, all the stuff which is required, hopefully before 12:30. So that by 1:30 you are ready to go into the cadaveric lab and start your dissection. So I think we can start, Dr. Surya.
Yes.
So I invite Dr. Praveen to give his first talk of the day. हाँ, कर दो. He's in.
So I have the pleasure of inviting one of the renowned faculty, not just nationally, but also internationally, Dr. Praveen Bharadwaj, sir. He's a consultant hand surgeon, and as he has already told you that he is an orthopedician by training. And he had done his MS Ortho from KMC Mangalore, followed by So he has done his MS Ortho from KMC Mangalore, followed by the prestigious fellowship in hand and microsurgery from Ganga Hospital. And since then, he has been a consultant in Ganga Hospital, and he has received numerous awards, and is the editor of the prestigious Journal of Hand Surgery, Asia Pacific Volume, and the academic coordinator for the Indian Society of Surgery of Hand, and the scientific committee chair for the upcoming Asia Pacific Hand Surgery meeting in 2025. He has numerous publications to his credit, 124. I think you must have read some of the articles which I had shared in the Google Drive. So some of the publications are from Dr. Praveen Bharadwaj, sir. And he has special interest in brachial plexus wrist, and spastic upper limb. So I invite Professor Dr. Praveen to deliver his talk on management of BPI. Following this, we'll have talk on clinical assessment by Dr. Ketan Desai, sir.
हाँ ये वाला लाइट ऑफ कर दीजिए yes. Okay, good morning everyone. From the introduction it appeared that most of the people are exposed to brachial plexus, but they are for some time not doing it very often. So that way it would be quite nice to know about the anatomy, clinical examination, and also the general management plan for these injuries. So we have a small change in the order. The first talk was about clinical examination, but as Dr. Ketan joins us, I think we can have that later. I'll be talking about mainly on the overall management protocol for various brachial plexus injuries. When we have a brachial plexus injury, patients, especially the people who see it less often and are not very updated to what is the current trend in brachial plexus injuries, generally people have quite a very negative thought about brachial plexus, that anyway these patients, they never recover and the outcome for surgery is very poor. Especially among orthopedic surgeons, they feel as if nerve surgeries never work and the brachial plexus surgery especially never works. And we would very commonly see some patients who have been undergoing treatment for fractures continuously and waiting for the nerve to recover because it is thought that it may not recover. So that is the first message which I think everyone should know, is that brachial plexus injury actually can give very good results. So this is one patient who was doing second year orthopedics when he had this injury, and he was being an orthopedic surgeon. Still he was not undergone any surgery, and for 6 months he was roaming around thinking that some improvement will happen. And as the time passes, people are able to do some shoulder abduction with trapezius, some moving here and there, so he assumed that some improvement is happening, but actually there was none. So this patient, after doing the nerve transfers even at 6 months, was able to go back to his orthopedic practice, and he has started doing his orthopedic clinical practice now. A patient, young guy who is a professional cricketer, felt as if like his life is finished there and he will not be able to do anything. And this is the level of improvement we can expect after nerve transfer surgeries. So the nerve transfer surgeries which have come in last maybe around 20 years have dramatically changed the outcome of brachial plexus surgeries. And hence, should we continue or go in correct order? Examination first? It's okay. So the surgeries can really give quite promising results, and patients can very often go back to their normal activities and be socially productive and comfortable in life. So one message which anybody who is starting to do brachial plexus has to have is a positive outlook that the surgeries are quite effective and it is worth learning them and worth practicing them. So there are many general misconceptions like results are poor. As I showed, it is not true. Most would improve with time. Surgery is not that effective. Treatment is very complex. One common thought is most of the nerve injuries may recover, but actually no. Only a low velocity injury, especially patients fall at home having a closed shoulder dislocation, having brachial plexus injury, those low velocity injuries are the only things which may recover with time. They often recover, but high velocity injuries don't recover that often. Treatment is really not complex. Once you get to know the overall management plan, I think there are only about 6 or 7 different plans which are possible, and then it appears like it is an automated thing and every day you are doing almost the same thing. Yes, patients may initially appear as if they are having variable presentations, but all of them would follow a definite pattern, and hence management is not that complex at all. So patients may have shoulder involvement, C5, C6, that is shoulder and elbow, extending to the wrist, extended upper plexus palsy, or they may have a global involvement or involvement of only the lower roots. So these are the basic 5 combinations which are possible. So that does not make the management actually quite complex. There are 3 basic things which we require to know when we start doing brachial plexus surgeries. One is the anatomy, and also be aware about the various anatomical variations which are possible, which are quite common and can be quite irritating and confusing when you get that case in your very early in your practice. We must be very comfortable in muscle examination, how to clinically examine various muscles in the upper limb, which we are going to have a talk now. Knowing these 2 things, then it only comes to having a systematic approach. And that we are going to see in this talk. Basically, the brachial plexus injuries can be divided as a complete brachial plexus palsy or partial palsy. In complete palsy, there is involvement of all the 5 roots. So that means right from the shoulder to the fingertip, patient will not have any movement and not have any sensation. These are the most complex of all the cases, when the management and the result wise also. The partial palsies can be basically of 4 types. One is a partial involvement of only the C5 root, which will cause paralysis of the shoulder. So that means C5 goes to the shoulder. C5, C6 palsy, where along with the shoulder there is paralysis of elbow flexion as well. So C6 basically represents elbow flexion. The extended upper plexus palsy has involvement of C7 root as well, and partly C8 sometimes. So these both come in extended upper plexus palsy. Here there would be wrist drop and weakness of the triceps. Why I am stressing on weakness of triceps is because one of the nerve transfer which is done to improve shoulder abduction requires triceps to be normal. If triceps is not normal, then that nerve transfer cannot be done. That is the importance of knowing that whether there is an extended involvement of the brachial plexus. A much less type involvement is a lower plexus palsy where C8 and T1 roots are injured. Here the patient would have almost normal function of the elbow and shoulder. They will have a decent wrist extension, but there may be only one wrist extensor working, that is the ECRL. They may have paralysis of the ECRB and other wrist extensors, and there is no flexion of the fingers. So this is an uncommon injury, sometimes called as a clump case palsy, especially when it is happening in pediatric population. Interesting thing is we hardly require any investigation for diagnosis. So diagnosis can be always done by the clinical examination itself. But investigations could add to some information about the level of injury and whether there is any recovery which is happening. Now, when we need to investigate, many times you would see a patient who has an injury and day 1, day 2 itself he would have gone and undergone an MRI and undergoing repeated nerve conduction studies up to checking the nerve. It is really not required. The MRIs and nerve conduction studies are thought to be best done around 4 to 6 weeks. Because if you do a nerve conduction study within first week of injury, the nerve may be still conducting. You may get a false result. And there are no good evidences of the recovery not happening before that time. So good time to do all the investigations, MRI, nerve conduction study is somewhere between 4 to 6 weeks. Now, when do we operate? When it comes to brachial plexus injury which has not shown any recovery at all, 6 weeks is a good time to think of doing surgery. Why 6 weeks? Because it is thought that all the neuropraxias would recover in 6 weeks. And if it is anything more than neuropraxia, then the recovery is unpredictable. And since it is unpredictable, better is to operate and have some control on what improvement is going to happen in that patient. Till then, the patient can be managed with the regular physiotherapy, mobilization of all the joint, stimulation of the muscles to keep them in good tone. 6 weeks may be the starting point of doing the surgery, but we could wait for about 3 months maybe in upper plexus palsy. But when it comes to global palsy, we should try to operate early, because in case you are having some root and you are going to innervate the hand, you require to go early for the nerves to reach for the fingers to get some movement. Because we know that the muscles survive only 18 months without an innervation. So if we consider you are doing a brachial plexus repair here, our forearm muscles are almost 18 inches away from the brachial plexus. So we need to operate early. But when it comes to elbow, we could wait for about 3 to 6 months, not more than 6 months in any ways. And for shoulder also, 4 to 6 months should be quite okay. But the golden period ends at 6 months. After 6 months, the result will not be that good. Even all the nerve transfer series also show a dramatic change in the outcome at about 6 months. What can be done if the patients present late? If the patients come late, there are still some options which are called as a secondary procedures, which could be tendon transfers, arthrodesis, or free functioning muscle transfers. But these do work, but they don't work as good as the nerve surgeries. So that's why I think the emphasis has to be on doing early nerve surgery. That is the one which is going to give the best results. Now, what are the types of operations what required to do? One is the nerve repair, that is the end-to-end joining of the nerve. Nerve grafting. Most of the times whenever we are doing a brachial plexus surgery, we would be doing after a few weeks. So nerves hardly come end to end. There will be mostly some gap there, and you will require to cover that gap with a nerve graft. The third type of surgery is the nerve transfers. Nerve transfer surgeries are done away from the site of injury, not in the plexus, distal, very close to the target muscles. Since they are done very close to the target muscles, the recovery is fast. And since they are away from the zone of injury, again the chances of recovery is better and more predictable. How it is decided is basically depends on the type of nerve injury and when the patient is presenting. If the patient presents early, it is always good to try to explore the plexus. If the original roots are available, we need to use them to do grafting and achieve the function, because whatever original axons are there, they have the maximum flow. But if the patient presents late, suppose we have a patient presenting at 6 months and having an upper plexus injury, doing a nerve grafting over the plexus area may not give a good elbow flexion for him. So at 6 months, you could go distally very close to the biceps, take a fascicle from the median and ulnar nerve and do a distal nerve transfer. That will work better. So when we are operating early, we could be more towards doing a nerve grafting or nerve repair. When we are doing operations late, maybe around 4 to 6 months late, then we go more towards the distal nerve transfers. However, most of the times the type of nerve surgery will be dictated by the injury itself. So whenever patient has got an avulsion of the roots, these avulsed roots will not permit repair of these roots because the proximal cut end is not available. And when proximal cut end is not available, you are not having the choice of doing a nerve grafting. So you need to search an option of either a working nerve, which is not injured, or you have to go for distal nerve transfers. But when we have a rupture, that time we have a choice of using that ruptured root for doing a nerve grafting procedures. Usually nerve grafting would be possible in this kind of nerve repair would be possible in kind of open injuries, cut injuries around the neck. This patient presented to us after 6 weeks of injury. This is his photograph at the time of injury, but he presented after 6 weeks. 6 weeks was taken to think that maybe some neuropraxia is there, so he may recover, which did not. He required a nerve graft. And nerve grafting at this level could give an amazing, perfectly normal type of result because the gap is small, the muscles are nearby, we are doing at good time. And this patient finally attained almost a normal looking shoulder and elbow function. However, if the root is not available or the patient is presenting late, we can opt to do these type of distal nerve transfers or a terminal nerve transfers, which are called as. Now herein, I would like to show this example here. So this patient, there is a avulsion of the C5, C6 roots. And since there is avulsion, we cannot repair that. So what we can do is, we have a nerve, spinal accessory nerve, which is going very close to the plexus. It is not part of plexus. So most of the times it is not injured. However, it can be injured. 7% of brachial plexus patients may have injury to the spinal accessory as well. Now this functioning spinal accessory nerve can be taken and transferred to the suprascapular nerve. Over here, so suprascapular nerve is detached from its the original place and attached to the spinal accessory nerve. Now we can see the nerve spinal accessory is functioning. It is connected to the suprascapular nerve. It is just about 2 inches away from the supraspinatus. So that means we will start seeing recovery within about 3 to 4 months, and 6 months you can expect the patient to have shoulder abduction. So that is the advantage of doing the nerve transfers. The boom into nerve transfer surgeries actually came from this operation, which is called as the Oberlin procedure. And in this operation, what is done is, so this operation is done to renervate the biceps and the brachialis. This is the biceps motor branch. This is the musculocutaneous nerve. So the biceps motor branch is taken about 1 inch away from the entry into the biceps, and one fascicle from the ulnar nerve is taken and transferred to this biceps motor branch. So how this transfer is done is, you do an intraneural dissection of the ulnar nerve, find out the fascicle which is matching in good size to the biceps motor branch. Generally, initially it was thought that we need to take a fascicle which is going to the FCU, but now it is thought that any fascicle we take should be fine. And this fascicle is then transferred to the biceps motor branch. And since the transfer is done just about 1 inch away from the biceps muscle, the recovery can be seen within 2 months. And this operation has really brought out a new life to the brachial plexus surgery. And after that, many new transfers have come, which make the results quite nice. So this is one article which we had written some time back, and it has all the details on how to select a donor, which operation suits best for which type of patients. Now let us see each level, some examples and the management strategy. So this patient, C5 palsy, as I told, there will be only paralysis of the shoulder. So here we have done spinal accessory to suprascapular nerve transfer. So it innervated the supraspinatus and infraspinatus. Other important shoulder abductor is the deltoid. We can take the long head of triceps motor branch and transfer to the axillary nerve. We will see a video on this in the next session. By this, we are innervating the deltoid now. So two main shoulder abductors, the supraspinatus and deltoid, are innervated, and it can result in a good shoulder abduction. We can expect the patient to achieve almost 150 degree of shoulder abduction if it is a C5 palsy, and on average about 125 degrees in a C5-C6 palsy. Coming to the next level where there is involvement of the elbow as well. Here the nerve transfer, two nerve transfers would be done same as what we did for C5, one for the supraspinatus, one for the deltoid, and two nerve transfers are done for the elbow flexion. One is for the biceps, one is for the brachialis. One fascicle of the ulnar nerve is taken and attached to the biceps motor branch, and a fascicle of median nerve is transferred to the brachialis motor branch. So since we are doing 4 transfers, it is commonly told as quadruple transfer. And this is the kind of improvement we can expect with this patient. If patient has involvement of C7 root also, we have two options. Either we do the same combination of nerve transfers for the shoulder and elbow and do the tendon transfers for the wrist and fingers, or we could opt for a pronator quadratus to the ECRB innervation, which we are going to see a video later to get the wrist extension. However, for finger and thumb extension, they will require a tendon transfer surgery once the elbow and shoulder is recovered. But eventually we can expect a decent amount of movement improvement in these patients, and they will be able to go to their normal activities. The global palsy still remains a challenge. So there are various ways in which people tackle it. Many people use a contralateral C7. Some people use intercostal and spinal accessory combinations. But this is the protocol what we follow. We tackle these patients in 3 stages. The stage 1 basically is for innervating the biceps. We do spinal accessory to musculocutaneous transfer for elbow flexion. In second stage, we do a trapezius transfer to stabilize the shoulder and fuse the wrist. And in third stage, we do muscle transfer for getting the finger flexion. So this is the typical patient, global palsy. He underwent spinal accessory to musculocutaneous transfer and later on trapezius transfer. Finally, an intercostal innervated free functioning gracilis muscle for finger flexion. And this is the kind of eventual result what we can achieve. It is not a very normal hand, but it is a functional hand where we started from totally zero function. Patients generally would be able to carry a bag of around 2 kg. They can lift some weight, and what many patients appreciate is that they are able to drive a two-wheeler. Though the injury has happened with the two-wheeler, but still think most of the patients feel that they want to drive a two-wheeler. And this is the thing which makes them quite happy, and many are very bike enthusiasts. They go back to again their biking and doing all activities. If patient come late, similar type of protocol can be used by doing a free functioning muscle transfers, and again you could achieve that level of function where they can have a decent amount of grasp and able to lift some weight and use this hand as a supportive hand to the other hand. In lower plexus palsy also, generally these patients present quite late because they think like things are going to improve. So these patients, we again offer them tendon transfer surgery. Here we have done a biceps to finger flexor transfer, and this is the level of flexion they can achieve with biceps to finger. And this also can be translated to a decent amount of function. This patient is after biceps to finger and brachioradialis to finger flexion, thumb flexion transfer. So to summarize, the brachial plexus surgeries may appear very challenging and management may appear very complex, But as you would have seen in the talk, there are basically only 5 combinations which are required. And if we understand that and master that, the brachial plexus surgery actually would be quite like a mathematics, 1 and 1 is always 2. Thank you so much.
Thank you, Dr. Praveen, for that excellent talk. I welcome Professor Mahapatra, who's been our head of department, chief director of many institutes, and father figure, mentor for all of us. So I again welcome him for this workshop. I also welcome Dr. Ketan Desai, who is a regular at our workshops, and we really benefit from his teaching. So thank you again for coming over here, sir. So now I'll invite him immediately for the first talk of the day.
Good morning, everybody. I would like to thank Professor Deepak for giving me this opportunity, and this is really a good endeavor to teach young neurosurgeons to learn few things regarding brachial plexus and peripheral nerve problems. This is not a very common practice so far as neurosurgeons are concerned, and this is a good initiative to encourage them to do this subspecialty. What I would talk very briefly on that, what are the clinical steps which one should undergo while encountering patients with brachial plexus injury. So basically, the main thing what you need to know is the anatomy. Without knowing the anatomy, you cannot diagnose a brachial plexus problem in a way which one should ideally do it. So anatomy is very important, because anatomy will let you know that which all neural elements are involved, and secondly, what is the level of injury in the brachial plexus, and that will further help in management of the patient. So anatomy is very important. The etiology, generally we all know what are the mechanisms. I'll just briefly go through it. Some part of the classification of brachial plexus, and Dr. Praveen has already gone through, which I will not go into detail of it. So basically, brachial plexus is a network of nerve in the neck, which goes from the neck into the axilla, and then its branches going into the arm and the forearm and hand. It's basically formed by, as we all know, primary rami, anterior primary rami from C5 to T1, and there can be sometime prefix or postfix brachial plexus, mainly based on the involvement of the C4 or the T2 root. So this is I'm sure everybody would know it, but basically you need to know that what are the levels of the brachial plexus elements in the neck and in the axilla. Basically the roots and the trunks are basically in the neck, the divisions are underneath the clavicle, and the cords and its branches are in the axilla. So that is how the brachial plexus is formed. Basically the C5 and the C6 root unite to form the upper trunk, and then it divides into divisions. The C7 continues as the middle trunk, and then it divides into anterior and posterior division, and C8 T1 root forms the lower cord, and then again it divides into divisions. So all the trunks ultimately divides into divisions, anterior and the posterior division. All the posterior division unite to form the posterior cord, and then subsequently it divides into the terminal and its branches, while the lower trunk continues as the medial cord, and the anterior division of the C5-6 unite to form the lateral cord. So I'm sure everybody would be knowing it, and I would urge all the young people to know the anatomy with relation with the human body very well, so that you know what type of injury this patient has. I would recommend that at least you should know the anatomy of main nerves like median nerve, ulnar nerve, axillary nerve, radial nerve, that musculocutaneous. That is very important. At least when you will know the anatomy and the nerve function, then you will be immediately able to diagnose the problem of brachial plexus, and at what level or at what site the brachial plexus is injured. Mainly, as we all know, that etiology is motorbike accident, which is one of the major cause of brachial plexus problem. In my experience, at least 80 to 85% patient had motorbike accidents. The other causes are fall from height. Sometimes there can be sport-related activity with mainly traction injury. Sometimes there can be a penetrating injury. Birth palsies are altogether a different problem. And in very rare circumstances, there can be missile injury or fall of heavy object. Post-radiation brachial plexus injuries are also known following radiation treatment in the neck and axilla, mainly in the carcinoma of breast and malignancy involving the neck. One should, when one examine patient of brachial plexus problem, always search for associated injuries, and they are always in quite a significant percentage of patient. The birth-related palsies, the bony injuries are always there, and you should look for whether there are any associated bony injuries like humerus fracture, clavicle fracture, which is also a common problem, cervical spine injuries, dislocations of the shoulder. Sometimes dislocation of shoulder can result in axillary nerve palsies. So you should always search for those associated bony injuries. Sometimes they can be associated with spinal cord or head injury, and in very rare circumstances there can be vascular injuries like subclavian or axillary artery damage. Mainly the mechanism, what it works is that mainly the main cause of brachial plexus is traction injury, and there is a direct. What happens is that when an insult or an impact happens, the head is sort of tilted towards the contralateral side, from the side where the injury happens. As a result, there is traction on the brachial plexus elements, and this traction causes the brachial plexus damage. Since the C5, C6 roots are a long segment nerves, those traction effects are certainly more common in the C5, 6 root, and that is why those involvement are very common. The segment of the C8, T1 is very short, so that is why that gets slightly less affected than the C5, 6. So basically it's the traction problem. Sometimes there can be direct trauma on the supraclavicular region in the neck, causing contusion of the brachial plexus element, causing injury. And there can be very rarely compression of the neck, which can sort of injure the brachial plexus and cause brachial plexus injury. So these are the three common mechanisms as is demonstrated here in this figure. The first one is the traction injury, second one is direct trauma, and the third one is the compression problem, where the neck is tilted towards the side of injury and causing impingement or pinching of the brachial plexus. The classification, as Dr. Praveen has already said, broadly is 4 types, and then there can be subtype of the Erb's palsy. Erb's palsy, classically the C5, 6 root to trunk level problem, the upper trunk problem. When there is an addition of C7, it is an extended Erb. There can be lower root involvement, which is the clump, which is not very common. And the more commonly presented problem is the complete flail arm injury, where patient has a monoplasia of the upper limb. So what happens in Erb's palsy? Generally, as I said before, that the problem is involving the C5, 6 root to the trunk, and the muscles which are affected are those muscles which are supplied by C5, 6 root, mainly the supra and the infraspinatus, deltoid, biceps, brachialis, and to some extent supinator muscle. So when you know that what all muscles are involved in an Erb's palsy, automatically you will be knowing that what would be the deficit. So patient will have deficit of abduction of the shoulder, the initial abduction due to the supra and the infraspinatus affection. There can be external rotation problem. These are the function of supraspinatus and infraspinatus muscles. So one should know the function of the muscle, then only you will be able to localize the problem. When the deltoid is affected, the abduction beyond 30 degree is affected. Biceps is the flexion of the elbow, similarly brachialis, and to some degree supinator, although it's supplied by the radial nerve, but the contribution is from C5, 6. So the supinator function is also affected. So when this all combines, this is the classical polystip or the waiter's tip sign, where the patient is unable to abduct the shoulder, he is unable to flex the elbow, and the arm is pronated with the palm facing backwards. So this is a classical form of the motor deficit in Erb's palsy. There can be associated sensory loss involvement in the C5, 6 dermatome along with that, and there can be wasting of the muscles which are involved. So this is a classical Erb's palsy which one would get. And this is a deformity which I already enumerated, which results as a result of palsy. The extended of palsy is, as I said, is addition of the C7 root to the middle trunk, and in addition to the of palsy muscles which are affected, the triceps and the brachioradialis also get affected, and there is an additional sensory loss in the C7 distribution with wasting of the triceps muscle in addition to the other muscles which are involved. The clump paralysis is mainly involving the C8T1 root to the lower trunk, and there is a classical claw hand. So here anatomy of the median and ulnar nerve is very critical. One should know the anatomy of median and ulnar nerve, what all muscles are supplied by the median and ulnar nerve. So this would be the one exercise which you should all read properly the anatomy of the nerves. Because of shortage of time, I'm not going into the details, but this is a very, very classical presentation in the lower root problem, where there is a claw hand, and along with that there is wasting of the small muscles of hand. Patient is unable to have any good hand grip, and there is a sensory loss in the C8T1 distribution. And in complete flail arm injury, there is involvement of all the roots of the brachial plexus. Everson injuries are more common in complete flail arm injuries, because the force which is exerted on the brachial plexus is more severe, more violent, and that is why all neural elements get injured. It's a more severe form of problem and more difficult problem to manage. There is a monoplasia of the upper limb, there is no movement. Along with that, there is sensory loss in the C5T1 distribution and muscle wasting of varying degree in the muscles of the upper limb. So associated with that, the main problem is neurogenic pain in the flail arm problem, and Deepak is managing those type of patients very regularly. But this is one problem where sometimes patient says that if the function doesn't return, I am okay, but get me off this pain because this is killing me. And neurogenic pain are more common problem in complete flail arm brachial plexus problem, and it is sometimes very, very difficult to manage, and sometimes the final stage of management, the lesioning is done in the cord. So in addition to this problem, one should also note for some other associated problems which are there in brachial plexus injuries, like Horner's syndrome, where more common in the lower root injuries, more common in the everson injuries, where there is partial ptosis, meiosis, decreased sweating on the affected side of the face. So always look at Horner's syndrome. So always look for winging of scapula because of the serratus and the rhomboid palsy. Always see whether patient has got history of shortness of breath because of phrenic nerve injury. Shoulder function like shrugging should also be tested, because you are going to utilize the spinal accessory nerve for the nerve repair, and one should document that whether the spinal accessory function is normal or not. If we are going to utilize that spinal accessory, the function should be adequate enough to help to regenerate the damage now. So that should also be, trapezius function should be assessed. Also look for vasomotor symptoms, because of the brachial plexus problem, there are vasomotor changes like dry skin, sometimes there can scaly changes, and this is mainly because of the sympathetic activity getting affected. Trophic changes can also happen in brachial plexus long-standing problems. And as I said, neurogenic pain is one of the common presenting problem associated with a brachial plexus injury. So for students here, when one see a patient of a brachial plexus problem, how say this case comes in your exam. So these are the points you have to consider while putting a diagnosis. So first thing would be side. The second thing would be whether the injury is complete or partial. Then what is the etiology of the problem, whether it is traumatic or birth related or radiation induced. And then what is the type of problem, whether it's a traction problem or some penetrating injury. What are the neural elements involved? What is the duration of the injury? Whether there is any recovery noted to some degree over period of time, and age and sex of the patient. So say for instance, there is a patient with a C5-6 to 7 root to trunk level problem. The diagnosis should be like that this is a right-sided post-traumatic partial traction related, and whether there is a pre-ganglionic or a post-ganglionic injury, where that one can know more to some extent clinically, but more of after the investigation. There is a post-ganglionic or a pre-ganglionic brachial plexus injury, and these are the roots which are involved, C5 to 7 roots to trunk level problem, over duration, over 3 months duration, without any significant recovery in a 25-year-old age male patient following motor vehicular accident. So this is a complete diagnosis of a patient. Say for instance in exam it comes, this is the diagnosis you have to make and put forth when you encounter this type of problem. To briefly say what all management you do, as Praveen said, mainly the investigations are the MRI and the EMG, but at the same time, some basic radiological assessment should also be done, like chest X-ray, mainly with clavicle to see whether there is any clavicle problem, and chest X-ray to see whether there is any rib fractures, because if you are going to utilize the intercostal muscles, intercostal nerves, the rib fracture sometimes may be an hindrance that the intercostal nerve you may not be able to harvest. There can be some neuroma in the intercostal nerve, or there can be dense scarring around the intercostal nerve. So this information, whether there is any rib fracture, is important in chest X-ray, clavicle fracture, plus the most important is the diaphragm, whether there is any ventration of the diaphragm because of the phrenic nerve problem. Brachial plexus MRI is an investigation of choice. Previously, when we were resident, CT scan was done, CT myelo, but the CT was a more invasive test. So nowadays it is not commonly done, but however it is more accurate than MRI. MRI has got some limitations, and we all have seen that a patient on MRI has documented a pseudomeningocele, but simultaneously the function is still present in that involved now. So it all depends. MRI is basically the pseudomeningocele is just the rupture of the arachnoid membrane to have the CSF pooling and at that location where I have the injured nerve. But it may so happen that the nerve rootlets are not avulsed and they may be intact. So sometimes there can be fallacy in MRI, but there is a reasonable accuracy in MRI to, especially the large pseudomeningocele, to document that this is a avulsion injury. Nowadays, MRI neurography is also done to check the patency or the continuity of the neural elements, to document neuroma formation. And the common sequences which are preferred are the T1, 2 and the stir image sequences, which are very helpful. And what information you look at when you do an MRI is that you look for whether there is any hematoma, what are the soft tissue changes, whether there is any pseudomeningocele, whether there is any edema of the nerve, there is a neuroma formation, discontinuity of the neural element, and also atrophic changes. This is more important. Nowadays, in Western countries, the EMGs are generally not done. The information which one gets from the EMG are equally noted on the MRI. So atrophic changes which one looks at are seen on MRI of the involved muscle. So sometimes the EMGs are not done, but ideally it should be done as to have a proper complete diagnosis. So these are the information one should look at when one asks for an MRI. When we ask any test, one should know that what we want to look at. Just for sake of asking, one should not do investigation. So these are the points which one should aim to look at while asking for an investigation. And these are the common, the presentation in an avulsion injury, the pseudomeningocele. This is one case of a multiple level pseudomeningocele involving all the roots, and most severe form of injury. The CT myelo, which was done before, is relatively very accurate. Even a small pseudomeningocele can be picked up. And the main thing is that when there is a root avulsion, the foramina remains empty. And that is why in an oblique view, if you take a CT imaging, you can diagnose that this is a root avulsion problem. As I said, that the stir image is of really importance and help. One can document on neurography the continuity of the neural elements. This is a very classical example of a C5-6 trunk level problem, root to trunk level problem. As you can see here, this is a normal MRI, and you can see abrupt discontinuation of the neural element. And nowadays on MRI, interested radiologists do tractography also, and they can document the continuity of the neural element. As you can see on the right side here, is a total absence of the track, which is normal on the left side. So MRIs are helpful, and one should definitely do it. As Praveen has already said, that when one should do it, you should not do it immediately. You should wait for at least 4 to 5 weeks and then do all these batteries of tests like electrophysiology and MRI testing. EMG, I have got a separate presentation which I would do later on. Thank you very much.
Thank you, Dr. Ketan. Could we start? So I think we'll just break here for the inauguration, a quick inauguration of 15 minutes. And I'll hand over, where is our Rakshay, the master of ceremony, to Rakshay, please take over.
A very good morning to one and all present here. It is indeed a privilege to welcome you all to this amazing cadaveric workshop on brachial plexus surgery and beyond. I would like to now welcome our distinguished dignitaries onto the dais. I am humbled and honored to call upon the stage Professor A.K. Mahapatra sir, our chief guest of the workshop and symposium, founder president of Indian Society of Peripheral Nerve Surgery, ex-HOD Neurosurgery, and chief of neurosciences. I welcome you, sir. I request Dr. Surya to the stage with a bouquet of flowers. Welcome, sir. I would now request and welcome Professor Kamran Farooq, sir, Chief of Trauma Center, Professor and Head of Department of Orthopedics and Chairman of AIIMS Cadaveric Surgical Skill Training Lab. Welcome, sir. May I now welcome Professor Deepak Agarwal, sir, Director of this workshop and symposium and Indian Society Peripheral Nerve Surgery Secretary, and Senior Professor, Department of Neurosurgery. I would now like to welcome on stage Professor Vijay Sharma, sir, faculty in charge at AIIMS Cadaveric Surgical Skills Training and Professor, Department of Orthopedics. I would now like to welcome Dr. Rajesh Sharma, sir, Additional Professor of Neurosurgery and Co-Organizing Secretary, Workshop and Symposium, and Treasurer of Indian Society of Peripheral Nerve Surgery, sir. Welcome, sir. Finally, I would like to welcome Dr. Surya Krishna Gaur, sir, who is the Organizing Secretary of this workshop and symposium and the powerhouse of this workshop. Yes, and I would now like to extend a warm welcome to the invited guest faculty for this workshop and symposium, Dr. Ketan Desai, sir, neurosurgeon at PD Hindita Hospital, and Dr. Praveen Bhardwaj, sir, consultant and renowned hand surgeon at Ganga Hospital, Coimbatore. Thank you, sir. As a neurosurgeon, I can definitely understand how important our hands are to us. They are indeed our bread and butter, and it's not just for us. Every person, I believe, has his livelihood attached to his limbs, and an injury, rendering a limb powerless, is very unforgiving in a cruel slap from destiny. So we as surgeons have taken upon ourselves to put up a decent fight against this menace, and to learn the very procedures that help us to treat, at least, if not cure, this deficit before it becomes untreatable. So let us embark on this journey of learning the complexities of brachial plexus surgery as our masters teaches us with simplicity. I would like to request our respected dignitaries on dais to begin this workshop with the auspicious lamp lighting and Saraswati Vandana and ignite the fire of learning in all of us. I would now request our workshop and symposium director and ISPNS secretary, Professor Deepak Agarwal sir, to grace us with his words of wisdom.
Thank you, Rakshay. I welcome all the dignitaries on the dais, and especially Professor A.K. Mahapatra, who's been our mentor and guiding light for continuous training programs since when he was there with us, and Professor Kamran, who has always been encouraging us in doing these kind of workshops. Professor Vijay Sharma, who's the chairman of this cadaveric lab, not the chairman, the actual person behind the cadaveric lab, and he has really improved upon the frequency and the quality of training which is now available in our lab. So I really wish that it continues this way. And this brachial plexus workshop we try and do at least once a year, because firstly it is one of the mandates of ISPNS society, for which I am the secretary, to have these kind of workshops. And secondly, we are one of the few centers which are doing a lot of brachial plexus surgeries in India. So it makes sense that we learn ourselves and keep spreading it to other centers in India. So with this, I really welcome you all to this workshop. We have a very nice academic feast for you today and tomorrow. Thank you.
Thank you, sir. I would like to now request Professor Kamran sir, Chief of Trauma Center, to motivate us with his inspirational words.
Good morning to all of you, and again a warm welcome. And thank you, Dr. Deepak and Surya, for organizing this. What I can say is that Professor Mahapatra, when he was professor here at Neurosurgery and then later on headed out of the department as well as a chief, he has always been very, encouraging. As it is, AIIMS is one of the premier teaching institutes of the country, and it is the mandate of this institute to impart knowledge and further it. And I'm so happy that the Department of Neurosurgery, they keep organizing such academic events, and now we are very fortunate that Dr. Vijay Sharma is there, and we have such a fantastic cadaver lab. I would say that you should use this opportunity to train yourself as much as you can. You have wonderful faculty. And one request I would have is that all of you should register for the website ACSST, which is there for the cadaver lab. One reason is that like Deepak and Neurosurgery, they keep organizing different workshops. I think last month we had, and Dr. Rajesh was there, he organized a pain, which is so relevant and pertinent in today's society. I mean, we are not doing workshops which are cliched or run of the mill, but actually he thinks of innovative and pertinent topics to organize the workshop. For example, pain management. I mean, I myself being a spine surgeon, we don't really focus that much on pain management. It's such a wonderfully attended workshop, and even like I can see in this brachial plexus workshop, we have such a good strength. So I'm very happy, and congratulations to Deepak and Surya that you have such a good attendance. And I would encourage you to keep organizing, have a schedule right through the year. And the good thing is that they're not being organized at the weekend, so people are very a bit reluctant to spare their weekend. So that is also another good thing. And congratulations to Vijay. I mean, ever since he has taken as the chairperson of the Cadaveric workshop, we are having it regularly. It's such a wonderful facility. If you go outside, these workshops cost you almost $1,500. I mean, anything from $1,000. If you can see in the AO spine, I mean, most of you would be members, I guess, but they are almost $1,500 to $1,000, which is a tremendous amount of money. And here you just have to pay about $15,000 to $20,000 for each workshop, which is a great thing. I mean, I would say that you should spread it in your institutes as well as among your resident groups or your consultant groups, and make use of it. Those who have come, you can come again, or at least spread this word among your peers that we have these workshops, and register for that will give you an information. Whichever one you want to attend, it will be very nice. And I'm very happy that we are able to carry forward the mandate of the institute by promoting education and academics, and bringing up future doctors who are, at par with anywhere in the world. And thank you very much for the faculty. You have taken time out for coming to Delhi and teaching and imparting your knowledge. Thanks so much.
Thank you, sir. I would now like to request Professor Vijay Sharma, sir, faculty in charge of AIIMS Cadaveric Surgical Skill Lab, to say a few words of guidance.
Thank you. Good morning, respected Professor Mahapatra, sir, Dr. Kamran, sir, Chief, Dr. Deepak, all distinguished faculty members and delegates. On behalf of ACSST, which was earlier CTRF when it started a few years ago, Dr. Mahapatra was there. So now it is changed to ACSST. I welcome all of you for this very, very important workshop. At any point of time, I think even in our wards, there are 2 or 3 brachial plexus patients. So number of patients are very high. And this is one field, I think, where it needs multi-speciality care. I don't know how many orthopedic surgeons are attending, but I think there is when we were with Professor Kotwal, sir, we used to do a lot of shoulder arthrodesis and trapezius transfer at that time. So that was, one OT was dedicated to some sort of sequelae of brachial plexus injury or some sort of problems. So like Dr. Kamran said, if you go on the site, you will have idea about how many courses we are conducting, from the basic courses to advanced courses. We are happy to tell you that we have now OAM in the cadaveric lab, and we are Medtronic has promised that in all the courses they will provide navigation also, so that we can devise some sort of OAM guided courses also for spine or other areas, pelvis areas. So I appreciate the effort of all the faculty members who have come from far off place just for one motto. I think their passion for learning and teaching, I think that is important. I congratulate Dr. Deepak Agarwal and his team. I think every week or every 15 days we have got one very good course, and or even on weekdays it is almost completely booked courses. So I congratulate and my best wishes to you. And this time cadavers are very good because we are starting with the new cadavers. There is these cadavers are all fresh cadavers. So I think I'm very sure you're going to like the cadavers also, and dissection is going to be very good. So I request delegates to learn a lot, all the skills here, so that you go to your places and utilize all these skills on your patients, because basic idea is to treat patients in a better way. So thank you, and best wishes for this course.
Thank you, sir. Now I would like to request our chief guest, Professor A.K. Mahapatra, sir, to enlighten us with his words of wisdom.
Good morning, Dr. Kamaran, Dr. Bijay, Dr. Deepak, Surya, Dr. Desai, Dr. Parmin, all other faculty and friends. I think you must know little about AIIMS, because many people are outside AIIMS. In 1942, the Bohr committee. Joseph Bohr was the professor of surgery at Cochin or somewhere. That time they were thinking to have a medical university, and that is near Quit India movement time. Then India got independence. That report they submitted in 1946 was not seen by the British Council. So it was first seen in 1947 after India independence. So they have written there should be a medical university. So when Rajkumar Amritkar was the health minister and India got republic in 1950, they thought they should have an all India institute, but there was no money, $250 million. So it is the New Zealand government gave one grant of $250 million that AIIMS started 1956. When the act came, the act was so well written by the health minister that only problem was that director should not have any power, that much of power. On 18 June 1956, one amendment happened in the Rajya Sabha. It was passed through the Lok Sabha. In the Rajya Sabha, that the director should not have financial power, because executive power and administrative power and financial should not be there. So they thought they should have a joint secretary rank officer, finance officer, to see that there is no corruption in finance. That's 1956, 18th of June. So this is how AIIMS started. Neurosurgery started in 1965. But then this trauma center is a big, long history. They know. 1971, they should have a trauma center. In 71. But it was always some Delhi government versus central government versus AIIMS. Delhi is a very complex place. So sometime went to Gangaram, sometime went to RML, but nothing happened. But officially in 81, they said chief of trauma center, Dr. What is it? Professor Chandra, Dr. Chandra. So they designated Dr. Chandra as the chairman of trauma center. So that is from where the ball started rolling, 1981. Then the land was allotted. This was the cricket ground. The people came and played cricket here. I joined here in 75. So this was the cricket ground, and it should have tournament of the students here. Cycling to the So then I think in 2005 and 4, Dr. Dabhe was director. Dr. Dabhe put a lot of effort when he was director and got about 20 crores. But then they started working, 20 crores was not enough. They kept on increasing, increasing. Everything was happening, then there is no operation theatre because there is no money for the manifold room, because operation theatre was in those days not having manifold room. We used to have oxygen cylinder and I think nitrogen cylinder and operate. So that was cost 1 crore. Everything was finished. Then the problem was who is going to be trauma center chief. So we made a 3 committee, Dr. Mehta, Dr. Bhan and Dr. MC Misra or some, I think. After that committee, they could not purchase because the cost was given, whatever money was given, MR, CT and ultrasound, all these machines could not come in 10 crores. So there are negotiation and cancel. So negotiations, cancel. 2006, they said that we will have a negotiation committee. Myself, Dr. Dogra from forensic medicine, and 3 people are there. So the people came, Siemens, Philips and all this. They were telling 18 crores, MRI, CT, ultrasound, mammography. But then we bargained it to 10 crores, that is the money available. That is how the trauma center, I said, we will not give you 1 rupee, what is the government giving. They were insisting, you approve it, we will get it passed from the government. Can you believe? If we approve 18 crores, the company will make it from the ministry. Same thing happened when we purchased Gamma knife. We had kept 25 crores. The company said, you make it 40 crores. I said, we will not give you anything more than 20 crores. He said, sir, why you are worried? आपको पैसा चाहिए ना, मैं minister करा दूँगा. I said, 40 crores. I said, what? 20 crores to 40 crores. He said, it's not big deal. Minister will do it, secretary will do it, all will do it. See, it is all possible if you are in Delhi, but one thing is very important, you will not boss to the politicians and bureaucrats, and the more importantly, the business fellows are these companies. You stand with firm and strong, they will come down because they are going to make profit. They are going to make profit. Even they sell you 20 crores after 10 crores, they are making profit. What is the cost of manufacturing? 2 crores, 3 crores. So the question is that trauma center is a good reality. Now this lab, there is nothing lab. There was no place for lecture theatre. When Dr. MC Misra took over, we said, where is the lecture theatre? There is no room for the faculty. I think these people don't know. So Dr. Misra and myself sat down. I said, where the people are going to sit? There is no common room. There is no tea room. There is no lecture theatre. This was a whole hall. So we started thinking a hall here so that 100 to 150 people can sit. Then we have broken some area to remodel the faculty room and a small seminar room, first floor I suppose. A small room, board room. Because in original planning there is nothing. There is no faculty room. They thought it's like a hospital where the people come and go and working. Consultant, they will come and go. So lot of things. Now, how to start a cadaver lab? We had just started a cadaver lab at AIIMS. Suri had started and we got 5 crores for that. 5 tables, each table about 80 lakhs and some maintenance charges. So Sumit was here. I took Sumit to the ICMR, DG ICMR. He happens from Agra and my classmate, Dr. Kotos. He said, how much money you want? I said, 2 crores, 3 crores. He said, 2 crores. Why not 1 crore? So we bargained for 1.5 crore. And we thought in 1.5 crore, will take 10 lakh drill, 10 lakhs or some small microscope, which is for experimental microscope. So we had about 4 tables. How many tables are there now? So we could manage with 1.5 crore, each table costing about 30 lakhs or so. The question is that where do the skill development comes in neurosurgery? When we are student, I joined in 78 and I came at junior resident for 3 months, then joined as a senior resident in 79, and I worked in neurosurgery for 38 years. Question is that it requires a lot of skill. When I was a resident, the neurosurgery was the only department where is a tabletop microscope like this, and we have to cut the rat. First they will cut the muscle, thigh muscle of rat and suture it. Then we have to cut the artery, femoral artery, and put few stitches. Towards the end, we have to have sciatic nerve cut and suture. I remember Dr. Dave also, Dr. Dave, Dr. Bhan, I don't know if Faruqi came or not, they all came to learn suturing the nerve and muscle from our lab, which was in the anatomy department. We had 2 rooms in the anatomy department. There we used to do experimental lab. That part was neurosurgery department. When neurosurgery department started in 1965, when new building was not there. The question is that from small lab, where the people of only AIIMS used to come, and then we made a rule in late 80s, all of our residents will go to the lab and do some suturing, so that every senior resident doing MCH will have few hours of, I don't know, Bansal and all these people are gone, or hey Datta, you had gone there or no? So actually we used to do, every resident will go and say, okay, we will learn it. It's very important for the neurosurgeon because today nothing are done without microscope, right? So microsurgery is very important to learn from lab, and we had made a lot of, I think, good experimental lab in neuro. I never knew if the animal lab, which is much better than AIIMS animal house. This animal house was made in maybe 70s or 80s. When I came here in 75, animal lab was there just next to the hostel. So animal facility and experimental lab was fantastic. There is anesthesia machine, there is a ventilator for that, but the veterinary surgeon, Dr. Sharma, never anesthetized anybody, any animal. So when you are doing the neural transplant in monkeys, he had never seen monkey cesarean. And we used to do monkey cesarean, take out monkey embryo at 3 months of age, take out the embryonic brain and put in the monkey who is artificially made Parkinson by giving MPTP. MPTP is a morphine congener. If injected in the brain, that will produce. So question is that our experimental lab is good, our setup is good, our planning is there, but first thing is mind to learn. So important thing is whether the resident try to learn or want to take a degree and go and practice. If your attitude is not learning, you can take a horse, but he may not drag the cart. So my point is that all residents should be properly trained. Today, if you go everywhere, even today, not many people do brachial plexus injury in Odisha. When I was in AIIMS director in Bhubaneswar, I took, I think Sumit Sinha came 3 times and did cadaver workshop. Only thing to say that people should learn suturing the nerve, suturing the muscle, suturing the vessel, because you never know when an accident and where. We all can have accident. One of our resident committed suicide. I'm not going to tell the name. He caught the nerve here. He in the hospital room caught. That was first 2005. And when the bleeding came and somebody saw the blood is coming from the room, we came to know that he has caught the hand. Immediately turned to around to our center, and I think Dr. Biswai sutured the radial artery and Dr. Sandeep Bass sutured the nerve. Within 1 hour. Imagine how emergency that somebody caught the hand to commit suicide and he's rescued and artery has to be repaired and nerve. It's not very far off. It is 1st January or 2nd January 2005. So it can happen to you It can happen to your resident, it can happen to your family member, and we have to all learn it. So first thing is attitude, temperament, and interest to learn. That is what Bhagavad Gita says. Tadiddhi pranipatena pariprasnena sevaya upadesyanti jnanam jnanam tattvadarsanam. It says it's only the man who is interested to learn. He learns from whom? He learns from those people who are jnani and the tattvadarshi. Jnana is knowledge, tattvadarshi is experience. And two words in Bhagavad Gita, jnaninam tattvadarsanam. Jnani means knowledge. To have experience, you have knowledge. Knowledge without experience is handicapped. You have degrees, you are a neurosurgeon, you never done an aneurysm. What is the meaning? So, jnana is knowledge, tattvadarshi is experience. So, upadesyanti jnanam, jnaninam tattvadarsanam. They, that means the gurus, give you jnana, don't have knowledge and experience. You see, is not Bhagavad Gita a wonderful book? Sadhavan labhate jnanam. That is for everything. If you are not interested, your son is not go to school, put 10 tuition teacher, he will still fail. Eh? Thank you very much.
Thank you so much, sir, for your kind words. Now I would like to request Professor Kamran, sir, to felicitate Professor A.K. Mahapatra, sir, with a memento. Thank you, sir. Now I would like to humbly request Professor Mahapatra, sir, to felicitate our invited guest faculty, Dr. Ketan Desai, sir, with a memento as a mark of our respect. Next, I will request to felicitate Dr. Praveen Bhardwaj, sir, with a memento. Thank you, sir. I would now like to call upon the powerhouse of this workshop and symposium and organizing secretary, Dr. Surya Krishna Gaur, for the vote of thanks.
Thank you, Rakshay. Good morning, all. It is indeed a wonderful occasion to have amongst us the founder president of ISPNS, one of the former president of the ISPNS, and one of the eminent international hand surgeons among us. They have spared their valuable time to teach all of us their learnings. Next, I would like to thank Professor Deepak Agrawal, sir, for his guidance, innovative ideas, and his unwavering support in organizing this workshop. I thank Professor Kamran Farooq, sir, for his unwavering support and providing the venue for the cadaver lab. And I thank Professor Vijay Sharma, sir. He's a troubleshooter and the faculty in charge of the lab who has provided us with 4 cadavers. And I would like to state that we have a total of 7 cadavers this time and 3 from anatomy. And Dr. Subhatra Ray, sir, has helped us in providing 3 additional cadavers. And I would like to thank Dr. Rajesh Sharma, sir, the co-organizing secretary, for his support, and all my senior faculty and colleagues from my beloved neurosurgery department, Dr. Shweta, Dr. Ramesh, Dr. Dattara, sir, Dr. Amol, and all of them. And I would like to sincerely thank the delegates who have come from all over India in this pursuit of knowledge. So we have around 40 delegates, and we had made sure that each delegate, there are only 4 delegates per table. So there will be 2 delegates per arm. So they get the maximum hands-on. So we made a point to limit the number of candidates. Otherwise, the candidates would have crossed 100. Last but not the least, I would like to thank my support staff, Vinay, Dr. Neha, Divya, Sanchit, Dr. Diksha, Siddharth, web team, Somnath and Sonu, from the Cadaver Lab, Manoj, and the sanitation as a CF department, and all my residents who are helping me out in carrying out this workshop, and the industry sponsors, Sun Pharma and Cellogenics. Thank you.
Thank you, sir. I would like to request everyone to gather around for a group photo, all the delegates and the panelists.
I think one more line of
Thank you, everyone. I would now like to request everyone to proceed for the breakfast outside. After that, we'll continue with the workshop.
the suprascapular nerve, which is the only branch which arises from the upper trunk, and there would be another because it's a very hectic job to continuously lift the clavicle to expose the trunk and the subsequent divisions of the brachial plexus. So this is how you look at, and you can find simultaneously identify, as you can see over here, the phrenic nerve, which lies over the scalene anterior. One has to remember that the brachial plexus runs from the medial to the lateral aspect. Phrenic nerve runs opposite. It runs from the lateral aspect to the medial aspect. So that orientation of the phrenic nerve has to be remembered, and sometimes phrenic nerve can be used for neurotization procedure, but if they are not going to use it, you should take adequate precaution to preserve it. And once you expose the brachial plexus upper trunk, then you can trace it more proximally to identify the roots. In the roots also, the orientation that has to be, especially the vein has to be adequately, identified, and if needed has to be ligated, because sometimes torrential bleeding happens from that vein, and your all repair and all would become messy. So suprascapular vein has to be identified, which runs just underneath the clavicle. Sometimes the orthopedic surgeons who does clavicular fixation, when the screw length is slightly larger, you can just penetrate through and through the clavicle and can injure the artery and the vein and cause bleeding. So that vein has to be done, especially in brachial plexus injury. The veins are quite severely dilated, and adequate control has to be taken care of. So this is how you do it. Then you subsequently mobilize the C7 root to the middle trunk, and then if needed, you can cut part of the scalene anterior muscle. Scalene anterior can be lifted out from the field to expose the lower root and even the subclavian artery and the vein. So this is the basic step of exposure of the supraclavicular exposure of the brachial plexus, and you can remember some few basic steps in your dissection also, so that you can. It's not that difficult to expose the supraclavicular brachial plexus. Now coming to the infraclavicular time, no? 2-3 minutes. Yeah. So coming to the infraclavicular exposure, it's a relatively very easy exposure. There's not much of structures which one encounters during the exposure. The ideal thing would be to take an incision along the deltopectoral groove from the clavicle down to the upper arm, and identify the cephalic vein. So that is very important. That would be a landmark of the deltopectoral groove. The cephalic vein runs in the groove, and you can see here that there is this cephalic vein which has been identified in the deltopectoral groove, and it separates the pectoralis major muscle and the deltoid muscle, this groove, and there is no need to cut it. Very by sharp dissection you can just separate out. Just you need to detach the pectoralis major attachment along the clavicle to some degree to reflect the pectoralis major medially, and expose the deltopectoral groove, and there is no need to ligate the vein. You can just preserve the vein and reflect out the two muscles. And once you do that, as it is done here, beneath would be the pectoralis minor muscle. So once you retract the deltoid away from each other and put a retractor there, the structure which you see is the minor. You can just either cut the minor, but I would recommend not to cut it, but detach it from the attachment, because underneath the pectoralis minor would be the medial pectoral branch, and sometimes while cutting it, you can injure the medial pectoral nerve. So better to detach it, and once you detach it, there would be infraclavicular fat, and in that fat would be the first structure which you encounter is the lateral cord. So the first structure which you encounter after opening up the pectoralis minor would be the lateral cord, and the lateral cord would be more superior and lateral to the axillary artery. The axillary artery, the orientation is based on the axillary artery. So the lateral cord is more superior and lateral. The medial cord would be more deeper and medial, and the posterior cord is more deeper and lateral. So this is the orientation of the cords in the brachial plexus, and one should take adequate precaution to prevent and injure the axillary artery and especially the vein. Sometimes the vein is quite dilated and inadvertently you can injure the axillary vein. So this is a exposure of the infraclavicular brachial plexus, the lateral cord, and you can see here all the elements of brachial plexus are exposed. The lateral cord is the first structure, and from the lateral cord arises the lateral pectoral nerve, and then the two terminal branches are the musculocutaneous nerve, which penetrates the coracobrachialis muscle to go into the arm, and the other is the median portion of the median nerve. The medial cord is more deeper one, and it is medial to the axillary artery, and the branches from the medial cord, as we all know, are the two cutaneous branches and the medial pectoral nerve, and the two terminal branches, the ulnar nerve and the median contribution to the median nerve. The lateral cord, from the lateral cord arises the lateral pectoral nerve also, which supplies both the pectoralis major and minor. And we do a lot of, sometimes do in selected cases, medial pectoral branch to the axillary nerve anastomosis, and that is where the medial pectoral nerve is identified from the medial cord and anastomose with the axillary nerve. So, and the posterior cord is more deeper from where the two subscapular and the thoracodorsal and the two terminal branches, the radial and the axillary nerve arises. And while dissecting the axillary artery, one should remember that there is this arterial branch, circumflex humeral, and that has to be, as far as possible preserved and avoid injury to the arterial branch. And that is, in short, the exposure of the brachial plexus, both supra and infraclavicular. I think more when you will do the dissection, you will understand more properly. Any questions?
Thank you, sir.
If you want to ask, just
yes.
Yeah. Just please ask any doubt, question. Please ask, because yeah.
So you said we do not need to cut the pectoralis minor, but you said we can detach it. So like, how do we detach it? We have to like
the coracoid process, you just detach it.
Okay, just using the
You can leave behind a sleeve of muscle so that you can reattach it. No, I don't do. Previously, when I started doing it, I used to cut the clavicle and do it. But you know what happened is, sometimes the movement causes the dislodgement of the plate, and then that callus formation itself causes a lot of scarring around the brachial plexus. So now I just create a tunnel to.
Do you suggest for learners, who are learning initial phase, they should do it?
Yeah, if needed, if they want it, they can do it. But then the clavicle fixation should be proper. Otherwise, even subsequent problem can happen. Yeah. You have to just create a tunnel under in the clavicle, cut the subclavius muscle and the vessels, and you can expose the tunnel. No, pec major is not needed to be cut. Just you have to detach some part of the pec major along the clavicle so that you can retract it medially. There is no need to cut pec major. No. So when the thing is that when you want to do say graft from the roots to the cord level grafting, then you need to expose the infraclavicular cord. Or if the injury is in the infraclavicular brachial plexus, like say axillary nerve problem or in the cord level problem, then you need to expose the infraclavicular brachial plexus.
Okay. If there are no further questions, I invite Dr. Praveen Bharadwaj, sir, to deliver his talk on spinal accessory to suprascapular anastomosis by anterior approach.
See, you will see these approaches on the cadaver when they demonstrate right now, then only it will be clear. Because in the images, it might not be the orientation, everything might not be clear at all. So when they show it on the master dissection just after half an hour, then you will get to see it.
Yeah, building upon that talk on the approaches. So in the supraclavicular approach, one of the common nerve transfer what one does is the spinal accessory to suprascapular nerve transfer. And this transfer is mainly to innervate the suprascapular nerve, which is going to supply the supraspinatus and infraspinatus. So it is to improve shoulder abduction and external rotation. So this is the scheme of the transfer, where we can see the spinal accessory nerve, which is most of the times uninjured, is transferred to the suprascapular nerve. Suprascapular nerve comes from the upper trunk. So this is the incision what I generally use, and I think spinal accessory sometimes can be very tricky to identify, and many people feel like, oh, it is quite difficult how to get it. So there are a few important points by which you will not have any difficulty in harvesting the spinal accessory nerve. And so we call it like 5 points to get it right all the time. So the first thing is the bony landmarks. So one of the known bony landmarks is that at the midpoint of clavicle, if you draw a line, vertical line upwards, the place where it intersects the trapezius, that is the place where you'll find the spinal accessory nerve. However, many times finding the midpoint of the clavicle is difficult because clavicle goes right out laterally, difficult. One of the easiest thing which we found is this top point of the acromion. We can see in our arm itself, there is a nice bony prominence there. And that is the top point of the acromion. The spinal accessory is always in this line. So you go to the trapezius, dissect in this line, and you will be able to find the spinal accessory there. So that is the first point. Second thing, you start dissecting on in the fatty tissue, in the fascia over the anterior aspect of the trapezius. That is the place where the nerve will be there. It is lying within the adipose tissue, so it is not just there. You need to dig into that adipose tissue to get it there. Then you will always have a sensory nerve which is crossing in a more superficial plane. Many times we may get confused whether this is the spinal accessory nerve. It goes exactly in the same direction, but it is more superficial. So the spinal accessory nerve is in the same level deep, parallel to it, but in the deeper plane, and lower down it would be going away from us. So the direction of the spinal accessory is very typical. It would be coming laterally first and then it will dip down and go. So that is one of the other important identifying feature. The next is there is always small veins which accompany the spinal accessory nerve. So while dissecting, if you have any bleeding, that means you are near to the spinal accessory nerve. We should not cauterize it. We need to just keep it pressed for a while and then again start dissecting, because if you start cauterizing, you may damage the spinal accessory nerve itself. So by these 5 points, we very commonly say that you don't require a stimulator. The stimulator is mainly to check whether stimulator is working or no. So by these 5 points, you'll always be able to get into the spinal accessory quite correctly. And all these points are actually mentioned, and little more details about this article which we wrote in our Journal of Peripheral Neurosurgery, which is the ISPNS official journal. So this is the small video of the spinal accessory to suprascapular nerve transfer. So as I told, the mark is over here, and that is the sensory nerve which goes in the same line as the spinal accessory. We are dissecting on the anterior border of the trapezius over there. And that is the adipose tissue in which I am dissecting, and then you start seeing the nerve. So nerve was not straight away visible. Once you dissect the adipose tissue, you'll be able to see the nerve. That white shining thing is the nerve. And we see that it is going vertically downwards. You hook the nerve, get it out, and then put the vessel loop onto it and confirm with the stimulator, or see whether stimulator is working or no, because many times the stimulator will not be connected that properly. Now, once the spinal accessory nerve is harvested, you go a little bit more deeper down to get a good length of the spinal accessory nerve, because we want to transfer it to suprascapular. We want a good length. So there are two important things in the spinal accessory harvest. One is we should not harvest it much proximally. If we have harvested it more proximally, we would damage all the innervations going to the trapezius. So typically, we should not even dissect it more proximally. Typically, we go as deep as possible. It has two advantages. One is you will get a good length, and whatever length we get it is a functioning nerve. So you can go more closer to the suprascapular nerve. Second thing, we leave the proximal innervation to the upper trapezius intact. So the main idea, the main philosophy of all the nerve transfers is when you are doing a nerve transfer, you are not denervating the primary muscle. So here the upper trapezius is preserved. We could even leave some branches to the middle trapezius, but the lower trapezius is paralyzed, which clinically is not so much significantly appreciated by the patients. So once we have got a good hold of the spinal accessory nerve, we have got a good length of it, then we go on to the identifying of the suprascapular nerve. Sir had already told about the suprascapular exposure. I will little bit show a bit more of it. So our main landmark for the suprascapular nerve is the omohyoid. So as he was also mentioning that you can take omohyoid, detach it proximally and reflect it downwards. This is the omohyoid, we have clipped it down. This is a very important landmark because suprascapular nerve goes exactly in the direction of the omohyoid. So we should not cut it distally, cut proximally and reflect down, and in that fat tissue is the suprascapular nerve. Many times if you are decided to do a nerve transfer, there is no need to dissect the plexus also. We are interested only in the suprascapular nerve. We could straight away go there. And in that fatty tissue, there will be some veins which you need to tackle, and that is the suprascapular nerve. Quite easy to get. It is in the same plane, same direction as the omohyoid in the deeper plane. And once you identified, just clip it and keep it aside. Again here, one of the principle of nerve transfers is the donor distal, recipient proximal. So that means whenever you are cutting a donor, you go as distal as possible, and when you are cutting the recipient, you go as proximal as possible. That is, you should not anytime fall short of length. In nerve transfers, nerve graft is thought to be the worst thing, so we should try our best to get an end-to-end coaptation. Having said that, it does not mean that you leave the nerve very loose. So once we have got adequate length, then we cut on the recipient so that we can go closer to the muscle. So again, just to show that fact that the omohyoid is a good landmark for the suprascapular nerve, they go in the same direction. And once you identified the nerve, this is another way of improving the exposure. This is called as a Bertelli maneuver. So what we have done is you raise the clavicular part of the trapezius, and once that trapezius muscle is raised, you can go more deeper near to the scapula area, and it will become more easy to identify. This is the trapezius what I am elevating, and once that is elevated, you will be able to go much deeper down, and you can see almost 2/3 of the part of the suprascapular nerve. Only that lower 1/3 which is going near to the scapula is not seen, but you could palpate it there. So I am palpating it through this hole. Even the suprascapular notch can be palpated, so you can identify whether there is any injury to the nerve. If there is any injury to the nerve, then we need to go by the posterior approach. So that way, by this Bertelli maneuver, you can get a good extent visualization of the suprascapular nerve and not miss any injury beyond. Because if there is any injury beyond and you do a nerve transfer here, you are not going to get any recovery. So that is the only indication in which we go by posterior approach. Otherwise, we always, and to again emphasize, these are the 5 points by which you will not have any problem in harvesting the spinal accessory nerve. And you see, this patient has got a very anteriorly placed trapezius. But even then, the spinal accessory nerve is at the same level as this top point of the shoulder. So if we go by the standard landmarks of dissecting on the anterior border of trapezius, we could sometimes get confused. And again, by following those same principles, you can go and identify the spinal accessory nerve quite comfortably. And again, emphasize on getting a more distal exposure so that you can get a good length of it and preserve some branches proximally. And once you have got a good length of the spinal accessory nerve, suprascapular nerve is cut more proximally, they come quite comfortably. You would never require a graft. If we are requiring graft, that means we have done something wrong. You should not require any graft. Sometimes if the plexus is avulsed and the roots have fallen down, you may have difficulty in retrieving it up. Again, the technique of that what called as Bertelli maneuver helps. You dissect the trapezius, go little deep down, so the suprascapular nerve comes more posteriorly, more closer to the spinal accessory nerve, but we should make sure that we get an end-to-end coaptation. So that is the procedure and that is the diagrammatic representation. If there are any doubts, I'll be happy to answer.
Dr. Praveen, I have 2-3 because
Yes, sir.
we do this routinely.
Yes, sir.
So what I have found is number one, when we are dissecting the spinal accessory nerve, so its branches to the trapezius, especially to the middle trapezius, they cause traction when we try to mobilize it. So sometimes it's not easy to mobilize it laterally to suprascapular nerve until you cut the branches, some branches. So I'm always afraid because it's not easy to distinguish between the branches going to upper trapezius and the middle trapezius. So
Yes,
how do you manage this? This is the first question.
Yes, sir. Sir, when we are dissecting on the deeper side of the trapezius muscle, the upper trapezius branches are already come.
Okay.
So that dissection is mainly to see whether any middle trapezius we can spare. So upper trapezius, if we have gone down into the trapezius, it is already innervated. So only thing is if sometimes spinal accessory itself is injured, so we try to go more proximally. If we are above the level of the trapezius, then you would denervate the whole thing.
Okay.
But if we have gone in depth, the upper trapezius is
It's
preserved.
already
Sir.
preserved.
Yes, sir. In
This-
fact, we have a big series of using that upper trapezius for trapezius transfer and it works. So that means it.
Next question is because we need a good diameter also.
Yes, sir.
And we want a length also.
Yes,
How
sir.
do you balance it out? Because you can keep going and dissecting deeper and deeper inside,
Yes, sir.
almost into the thoracic space.
Yes, sir. Yes, sir. That is a very relevant question, sir. And sometimes you are in dilemma whether you want a good nerve
Yes.
or whether you will paralyze the trapezius more. But the good balance is when the nerve is dividing into multiple branches, we cut proximal to that. If we see a discrete branch going to the middle trapezius, we will try to leave it. But sometimes it will be like a tail, 3 or 4 things it is dividing. Yes. Then we sacrifice and cut it more proximal because our the target function also is very important. So we not leave all of them and take a small twig because the patient may not see the trapezius, but he will see that the elbow has not come. Yes, sir.
Third question is.
Yes, sir.
You said to assess the viability of the suprascapular nerve.
Yes, sir.
That we can palpate the the notch.
Yes, sir.
How do we assess that it is viable based on that palpation?
No, sir, not viability, sir. Injury to the nerve.
To the injury, how
yes,
do
sir. So, so that basically we are seeing whether there is any neuroma in the nerve.
Oh, just the neuroma.
Yeah, neuroma.
If
sir.
we palpate something.
Palpable, yes, sir.
Okay, that
the
is
palpable neuroma. In fact, this guy Bertelli, he is a big proponent for upper approach. And now there is a big team which does only the posterior approach. So this person recently came out with a paper where he has cut the clavicle also and exposed from the suprascapular approach, and he has proved that even if injury is there, 90% of the times it is within that area of the proximal 2/3 which can be seen from the suprascapular approach. And if we find an injury, then we can go posterior, otherwise the anterior is okay. That is basically palpating for any neuroma, sir.
And for the suprascapular, to get the length again, we go upwards towards the trunk.
Correct, sir.
Now,
Yes.
when we are going upper, that is the area which is damaged.
Yes, sir.
So what I do is, because we have to, there is dense adhesions at that area, we do some kind of neurolysis trying to find the fascicles, keep going up, and where we find that the fascicles are absent, we cut it at that level. That
Yes,
is
sir.
my way of doing it. So I want to know how you do it to get the maximum length superiorly.
Yes, sir. Superiorly, we don't go into the trunk, sir. Just at the place where it is coming out of the trunk, we cut it. Because after that, it requires little bit intrafascicular dissection.
Dissection, correct.
So we rather mobilize it in the lower part so that it whole thing comes more posterior. So if it comes more posterior, it becomes more closer to the spinal accessory nerve, and try to take a more length of the spinal accessory.
Okay.
But since we are always identifying the spinal accessory first, so we just have an idea already that whether we are having a smaller length of it. If smaller length is there, then your idea of cutting into the the upper trunk may be okay. Otherwise, we will not require it, and just at the origin of the nerve itself, cutting should be sufficient. Yes, sir.
Also, what we have seen is that on all these brachial plexus injuries, the whole brachial plexus is shifted inferiorly
True, sir. Yes.
under the clavicle.
Yes,
So
sir.
the whole thing, I think, because of the traction or
Yes,
whatever
sir.
and the adhesions which scar formation.
Yes, sir.
So we use generally a zernie or some retractor to really, somebody is actually pulling down on the
Yes, sir.
clavicle.
Yes, sir.
So that we can go down and get that
Yes, sir.
nerve. Is
Yes,
that
sir.
your experience also?
Yes, sir. Sir, in our experience, actually, there is a little bit difference in our protocol itself. In global palsy, we don't innervate the suprascapular nerve. So we are not requiring to actually dissect. We are only doing spinal accessory to MCN. But in birth palsy, we commonly have this problem, what you are telling, that whole plexus is gone under the clavicle. So in them, what we do is we put the incision little bit just above the clavicle, not more to the neck. And through the same incision, we dissect below the clavicle also. Not starting like a typical infraclavicular exposure, just below the clavicle. So there, once we find the roots, then we can little bit push it up, pull on this side. In fact, many times the nerve graft is going across the clavicle, one coaptation here, another coaptation there. So in birth palsies, we do that, but in adults, pulling it is difficult. Children, it comes up. Children, we can, like this, when the anterior posterior divisions are dividing, that is a nice hooking point. You put an instrument and pull it up. It comes up almost an inch. But in adults, because of lot of fibrosis, it will not come up that much. So there it is difficult to do, but we are not requiring to do. In case we want to do, then again this trapezius dividing and going more deeper will be helpful.
Also, for identification of the accessory nerve,
Yes, sir.
do you extend your incision superiorly? up
No,
to-
sir. No,
You don't
sir.
extend.
No, sir.
Because that nerve is coming quite, it comes out superiorly at
Yes,
the
sir.
3, 5, 6 level.
Yes, sir.
So this is a horizontal incision? you're
Yes, sir. Only horizontal and in the lower part. And I think that's why we are always comfortable that the upper part innervation is preserved. We are not exposing proximally, only going deeper.
Between dorsal and ventral approach, dorsal approach offers us to be more nearer than muscle, to the suprascapular muscle. Won't it offer more quicker innervation than ventral approach?
Yes, sir. Yeah, that is right. So, but if you see the comparative studies comparing the anterior and posterior approach, same result. Because when you are doing by the anterior approach, you are maybe 1 inch difference is there. So that 1 inch would make difference of 1 month, which clinically is not that much appreciable. Only indication is, suppose you find it injured, then it is okay, because we always have to change the position. That is one thing which is a bit of uncomfortable thing. So if injury is not there, the documented results are the same.
Is it because of like you are taking more fiber from spinal accessory nerves and then taking?
Yes, sir. Interestingly, these people who are proponent of posterior approach, they say that the axonal count is not low down there, lesser in lower down. So they tell that the Ansa cervicalis contribution once add to it, the axonal count becomes same lower down also. So axonal count difference is not there, sir. Yes, sir. Yeah, that is a very good thought, sir. So all the studies which I have done for posterior approach, they have found that incidence of injury is 7 to 10%. But people who are more proponent, they say 1/3 have been found injured. So injury is at the notch level. So at the notch level, doing an MRI and finding is difficult. Some expert radiologists say that they can do an ultrasound and trace the nerve and can find a neuroma. If they are able to find neuroma, it may be good to go by posterior approach, but it is tough. It is quite tough. So we go by posterior approach only for patients where we have to innervate only the shoulder. And patient is coming after 6 months. So there we are not exploring the plexus, we straight away put him in the lateral position and do. Otherwise we always do anterior, check for the injury. If injury is there, then we turn him lateral and do the posterior approach. But it is difficult to find out preoperatively, sir. Yes. Because nerve is very deep. It's almost 2 inch deep from the skin over there. Yes, sir. Yes, sir.
Yes, said is absolutely correct that the two hindrance in this approach is to find adequate length of the suprascapular and spinal accessory to co-opt in a very tension-free manner. And as he rightly said that in majority of cases the brachial plexus is pulled down, and normally the level of the suprascapular nerve is just above the clavicle, about 1.5 centimeter above the clavicle. And when the nerves are stretched down, the origin of the suprascapular goes almost beneath the clavicle or inferior to the clavicle. So that is very critical. I said in my exposure that you need to have a robust assistant to pull the clavicle line, so that you can, from the microscope, you can see in a vertical trajectory the origin of the suprascapular, and then you need to mobilize the key. Sometimes when one finds that the length is not adequate, the reason is that you have not adequately mobilized the suprascapular. If you mobilize it, and as you said that you can palpate the knot, reasonably you go up to the level of scapula, then the mobilization is relatively very good. And as we said, some degree of mobilization of internal neurolysis of the nerve can be done, provided the most important thing is, Praveen, what you said, that why people prefer posterior approach and they say that the nerve is damaged. I also do by anterior approach. When you cut the suprascapular nerve, and if you find that the fascicle patterns are preserved, that means there is no distal injury. If there was a neuroma there, this fascicular pattern of the suprascapular nerve would have got obliterated because the nerve would have got denervated. So that fascicular, when you cut the suprascapular nerve, the fascicular anatomy, if you see the fascicle pouting out,
yes,
then
sir.
that means that the distal injury is not there. That is a very critical point. And majority of the time, the neuroma can be palpated if you put your finger. So the posterior approach can be avoided. And there is a very good paper that the anastomotic side of the anterior and the posterior approach differ only 2 centimeters. There is one very good paper they have studied.
1 inch.
So that 2 centimeter distance is not great in terms of renervation. So at the same time, you can simultaneously do some other exposure. You can do grafting. You can do other procedures like some fanic to some other nerve transfer. You may one go in the anterior approach. Plus, if you want to do distal anastomosis or overlean and all, you can do it in one go. Otherwise, you will have to change the position and all. So very good. And the spinal accessory localization is very difficult. Sometimes it becomes difficult. You will put like in a very difficult situation. The assistant would be feeling that this guy doesn't know how to expose the spinal accessory. Because in the scarring, sometimes there is scarring in the spinal accessory region also. And the critical point is that there is one vein which you should see between the scalene medius and the trapezius. That vein is a landmark. And if you can see the vein, then just medial to the vein would be this spinal accessory. And as you know that we are not taking the whole trunk of spinal accessory, we are taking only branch. major branch we are taking. That is why intraoperative stimulation to me is very critical, because when you stimulate, the strongest response which you get, that you should use for anastomosis. Then it is a good cooptation, because if the response is weak, and it may not come out with a good result. And as the nerve goes deeper, it branches out. So you should cut the nerve just proximal to where, as we said, to the branch, so that you can get a good cross-sectional diameter to the supraspinatus.
Yes, sir. Yes, sir. So success rate would depend on the other muscle working. So if it is a pure shoulder injury and you do only spinal accessory to suprascapular, it alone can get anything more than 90 degree, even 170, 80 degrees, because the supporting muscles are working. But if we are doing it for C5, C6, C7 pulse, you would get only 60 degrees at best. But if deltoid is added, then of course we'll get much range. So suprascapular alone, I think it would give only about 60 degrees of abduction. Percentage success rate in upper plexus palsy, 90%. But in C5, C6, 7, 70%. Yes, sir. Yes, sir. Yes, sir. So, yeah, functional advantages are over-adductivity surely become easy if abduction is good. Second thing is, patients who don't have deltoid, they mainly complain of two things. One is tiredness while doing activities with abduction, because deltoid is, of course, a very much stronger muscle. The second thing is the cosmetic, the contour is very flat. The whole family only keep showing that this is sagging down, this is sagging down, this is very flat here. In fact, some of the patients, they put a pad underneath here when they put t-shirt. So that is one thing which they complained a lot. So once the bulk comes, they feel very happy, sir.
Do you combine SOSAT then with
Yes, always, madam. Yes, always, yeah. We do by anterior, madam. That is the next video coming, yeah.
Isolated denervation of suprascapular, will it be able to give more than
No, isolated suprascapular palsy. Isolated suprascapular palsy patients, actually clinically they may be lifting full hand up like that. Only, yeah, wasting, if we see wasting on the infraspinatus area, and they will have tiredness. Because deltoid starts acting with after some abduction. So these people are like kind of bending their trunk and then lifting. So because of that adjustment pattern, they feel some tiredness. And if they see in the mirror, there is a flattening in the infraspinatus area. So only suprascapular innervation would give a very perfect result. But if deltoid also is paralyzed, then alone supraspinatus will give only 60-70 degrees abduction. But as you are telling, they are always, both are injured. So we have to do both transfer. We'll see that in the second part, sir. Yes.
Thank you, sir. Now I invite Dr. Ketan Desai, sir, to deliver his talk on Oberlin procedure, followed by ICNMC neurotization.
Just before I begin my talk, for all the young people, it may be difficult, as I said, to identify the spinal accessory. So if you start doing it, what you can do, and I recommend that you can identify the nerve proximally. Don't dissect it, but proximally from at the junction of middle third and the upper third. That is where the nerve comes out underneath the sternomastoid. And sternomastoid length, upper and the middle third, the nerve comes out, and you can just trace it distally so that you can relatively easily. That is what I started doing it when I began doing it. I didn't dissect it, but that was the point where I identified. So I would talk on the Oberlin procedure, which is the the horse of the whole brachial plexus repair, which is very commonly performed. But I'll just take the video and just talk a few points related to that. So Oberlin procedure, as you all know, is a nerve transfer procedure where the patient has got good hand function. The median and the ulnar nerves are functioning. Then only you can use those fascicles of the ulnar and median nerve to gain the elbow flexion, elbow function, elbow flexion. So basically the fascicles of the ulnar and the median nerve are utilized to join with the bicep branch of the musculocutaneous and the brachialis branch of the musculocutaneous. That is how you can gain good elbow function. And the anastomosis is very, very near to the target muscle. So the reinnervation distance and the time is short, and you can get a really good outcome with that. But I think before you embark on this surgery, to me, I think clinically the patient hand function should be good. And sometimes it may so happen that in the patient, the median nerve function or the ulnar nerve function may be good, and the other nerve function may not be that adequate. So you should do an EMG to NCV to see the CMAP of the ulnar and the median nerve. If the CMAP are relatively comparable to the other side, then you should use those nerves. Otherwise, if the CMAP are very low, and if you try to utilize these nerves for transfer, you may end up weakening the hand grip of what it was already weak. So basically, when you do this, the hand function should be reasonably good, and that is why it is generally done in C5 to C6 or C7 root to trunk level problem. The main thing is that the patient should be explained to that since you are going to manipulate and utilize the nerve, post-operatively they may have a little bit of hand pain, neurogenic pain in the, especially in the hand, or numbness in the hand, that you should forewarn them that this may happen for some period of time. But as the edema and all in the nerve settles down, then it will recover. So that is also you have to tell them. So the position generally what I do is that put the arm on the side rest table and mark the incision. The incision, so first and foremost step would be to expose the musculocutaneous nerve. So the first step is to identify the musculocutaneous nerve by a vertical incision along the medial aspect of the arm. So how you do it, that once you take the skin and subcutaneous tissue, you identify the biceps brachii muscle. So once you identify the biceps muscle, the musculocutaneous nerve goes underneath the bicep belly. So once you identify the bicep muscle, lift the muscle belly, and underneath would be the musculocutaneous nerve. So this is what the So this is the biceps muscle which is exposed, and now once you lift the bicep belly, you will find the musculocutaneous nerve. You should be pretty sure the median nerve is also very close to that. So sometimes, you know, if you don't take adequate care, you may end up dissecting the median nerve and then realize that this is not musculocutaneous. So you go, at the most, you can stimulate the nerve and see that this is median or the musculocutaneous. Generally, musculocutaneous doesn't stimulate. So this, once you identify the musculocutaneous, then press it a little bit distally to identify the biceps branch, the bicep brachii branch. There is a very large bicep brachii branch which comes out from the musculocutaneous, and that is the target now which one would need it. One has to remember that around that branch where the biceps branch is given, it is very vascular and there are a lot of veins around that. So you have to adequately, you know, take care of those small veins, and so that there is no bleeding, because once the bleeding happens, then you may end up coagulating around the nerve, which is not a good scenario. So once you do that, then trace the nerve distally and identify the brachialis branch. The brachialis would be around 3 to 4 centimeters beneath the bicep branch, which is going deep into the brachialis muscle. Once you do that, then as you see here, the median nerve, which is very easily seen, is identified, and just medial to the median nerve would be the ulnar nerve. You can use intraoperative stimulation to check the response of the nerve, and you can easily identify the median nerve and the ulnar nerve. So this is how the ulnar nerve is identified. Ulnar nerve goes on the medial aspect into the intermuscular septum. You don't need to dissect that much, but you should adequately mobilize the nerve so that the, in subsequent phase, when you anastomose the nerve should not get stretched out when the patient attempt to do elbow flexion. So this is how all the nerves are identified, and then this is the bicep branch. This is the musculocutaneous now brachialis branch, which I have dissected out. And once you do that, then you try to dissect the. So here I'm trying to dissect the brachial, the bicep branch from the musculocutaneous now. Now once it is identified, you see it is going into the brachialis muscle, the bicep muscle. So once you do that, then you start working on the ulnar and the median now. Cut the epineurium and take one fascicle from that. So one fascicle from the median nerve is given. Here in this case, I think the median nerve response was very strong. So I had utilized the median nerve fascicle to the bicep branch just to have a good bicep response. And it should be done under very high magnification. So this is the brachialis branch, which is anastomosed with the median nerve fascicle. You use 10-0 ethylon or proline. Take around 2 to 3 tack sutures and then put glue. I don't use only glue to anastomose it because it can give way and your whole purpose of your surgery can get defeated. And this is the brachialis branch is very long branch because there is quite a good distance before it enters the brachialis muscle. So that you can use it to the ulnar now, which I had done here in this case. So this is an ulnar nerve with fascicle which is identified. When you take this fascicle, you should see that you don't end up mobilizing all fascicles. Just target the area where you want to take the fascicle, take a small incision and dissect the fascicle out. Minimum handling of the nerve should be there. Otherwise, there would be a lot of nerve edema and post-operative sensory symptoms. So this is what is generally done here. The main thing is that once you do the anastomosis, try to bend the elbow and see that there is no undue traction on the anastomosis. That is why it is very important that this median and ulnar nerve are mobilized to some distance so that they remain lax and free when the elbow is flexed. Always do these 2 steps. One is this elbow flexion after anastomosis, and secondly stimulate the nerve after the anastomosis to see that there is a reasonable good function of the nerve still preserved after the anastomosis, and then you can do the closure. So don't forget to do these 2 steps before you close it. So any question you can ask. Hi, sir.
What is your preference for the median nerve fascicle? Do you stimulate prior to taking that?
Previously I had to do it, but now I'm just randomly take one fascicle, because there is a lot of Martin Gruber anastomosis which happens, cross anastomosis across the nerve, and generally the function is not that much affected because of that. Any point you want to say, Praveen, you can. No, because of time I couldn't show, the musculocutaneous mobilization is also very critical. You should be taking that musculocutaneous well a little bit higher up. Sometimes if you fail to identify the nerve underneath the bicep belly, come from above down, then it can be easily identified. Yeah.
Dr. Praveen. Yes, so, add to some points, some practical points which I think will be useful for everyone. As sir was mentioning, so almost 10% of the patients, the musculocutaneous nerve does not come lateral to the coracobrachialis. So that is one situation in which suddenly you may get lost that musculocutaneous nerve is not there. But that is one of the known variations. It is called as a Lee minor variation. So Lee minor type 4 and 5 will come medial to the coracobrachialis. That is along with the median nerve. So that will happen in 10 to 15% of patients. So that means if you are operating 10 patients, in one patient you may not find the musculocutaneous nerve. So long time back, if some 15-20 years back, if you see some papers, they will come as a case report of absent musculocutaneous nerve. But it is not absent, it is a variation of Lee minor where it is coming along with the median nerve. So it is also called as a low division of the lateral cord. That cord is dividing much laterally. The type 5 is very strange, in which it will look like a whole complex coming, and from that the biceps motor branch goes, brachialis motor branch goes, sensory goes, and it continues at the median nerve. So that variation we need to be careful. If you don't find the musculocutaneous nerve in the groove, then you identify the median nerve, trace proximally, and you can reach to the musculocutaneous, as sir was telling. Then regarding the fascicle selection, it is a big question. So whenever we are operating, for anybody seeing first question, they ask you
correct.
this only, sir. So in fact, I put a reference on that. So not that that is the Bible truth, what we have written in the article, but those are the thoughts which can be helpful. It is donor considerations in taking the donor for nerve transfers. So what all things should come in our mind? So when we are checking fascicle for nerve transfer, for ulnar nerve, there is no problem. You can take any fascicle. Generally, the anteromedial and anterolateral are the ones which are of good size match to the biceps motor branch. And size match is also a count of axonal match. So if you are size matching nicely, that means the axonal count also will be sufficient. So for ulnar nerve, no problem. Median nerve, there is a small issue. We also many times would take whatever easily separable, because there is a lot of cooptation in the nerve as it is going down. But for median nerve, they say that we need to be little bit more careful for two reasons. One is that the anterior interosseous component of the median nerve can be already separated out in the mid-arm itself. So if you are doing a nerve transfer for the brachialis, median to brachialis, where you are harvesting the fascicle little lower down, the anterior interosseous part would have already come out, and you should not take that component. It will cause anterior interosseous palsy. 2 of our patient had FPL palsy after the nerve surgery. So that is not nice. That is a very dangerous thing. So how to avoid that is, you go more proximally and harvest. So brachialis branch would come as a long branch. So you go above the mid-arm and harvest the fascicle. That is one thing. Second thing is, never take the posterior fascicle. Also, all the fascicles which are on the medial side are more of motor fascicles. The ones which are on the lateral side are more of sensory fascicles. So in median nerve, these two considerations we take. We don't take the lateral fascicle, we don't take the posterior fascicle. So if we are leaving these two, then there won't be any deficit, and try to go as proximal as possible.
We stimulate, when we dissect the fascicle, then with a very low current, we stimulate it. And then, then only we cut it. So, but as you said that the more preference is on the medial aspect than the lateral one, because the cutaneous branches, divisions are more on the lateral one.
That way we can have a...
But do you do that consideration that sometimes, the response of the ulnar nerve and the median nerve is variable? Yes. And then you change the anastomotic pattern that normally in an oberlin you take ulnar to the biceps and the median to the brachialis, but you change that
Yes,
anastomosis.
sir. We do, sir. In extended upper plexus palsy, where there is some weakness of the hand, very commonly the situation will be there, that either of the two, median or ulnar, will be working nicely. So then whichever is better, we put it to the...
And as I said before them, that the EMG is the NCV is very important. The CMAP of the median and ulnar now are really very helpful in at least pre-operatively deciding reasonably that what we should use it.
So sometimes the median is not at all, medial side of the hand is not working.
Yeah.
Ulnar is working. So what do you do?
So then I do face that. Then I anastomose the ulnar fascicle to the bicep branch. Only one, oberlin one, and don't do the two.
Or can we do it to the musculocutaneous directly?
No, it would not be the area of the muscular. No, the problem in musculocutaneous, there is a significant portion of the musculocutaneous which is sensory.
Yes.
The lateral cutaneous. So you will not be helping in that regard. You will use lot of part of the donor now, and the gain would not be that much adequate.
In musculocutaneous also, this Somsek only did a study where they are found that if you are to attach to musculocutaneous nerve, attach to the lateral and the central part. As sir is telling, big sensory component that is always on the medial side. So if we want some length, we can attach to the lateral and central part. That will go to the biceps and brachial.
In last few surgeries, what I have started doing is that I am dissecting in the intercostal to musculocutaneous transfer. I am dissecting the lateral cutaneous component away and only anastomosing the biceps and the brachialis component to the intercostal.
Yes, sir, that is also good, sir. In this one other thing which commonly, as you are telling, sir, biceps, brachialis. So we observed that whenever we have done this median to biceps, the recovery is nice, but these patients have difficulty in eating. So since median is a pronator, once it works maximum, the hand pronates. So this person, especially in Tamil Nadu, eating with right hand is very important. So people, they mainly complain that they are very comfortable bending nice, but when they are feeding themselves, the hand just slips down. So that is less common with ulnar, because the median is a pronator naturally. So somewhere that pronator torque is there. So if choice is there, better is to put ulnar to biceps. Thank you, sir. What is the
1
Are
million?
you also doing sensory?
No, I'm not doing it. No. Generally, as we discussed, there is no short point in that sense that this is the only, this fascicle is going into the FCU or not. That is very difficult to say because there are a lot of cross anastomosis which occurs in the nerve. So if you stimulate proximally, it may so happen that this may not be the target which is going there. So generally, in ulnar nerve, generally the problem doesn't happen. Reasonably they can maintain. Yeah. So any question regarding this Oberlin? This is a very simple surgery, and I think one of the most commonly performed surgery, and you should sort of learn it so that you can do it. So I'll just come to the next one. Shall I start the next one?
Yes.
Yeah. So this is the intercostal to musculocutaneous anastomosis in a patient with a complete flail arm injury. The two most important things are there while giving position of the patient. The position should be in supine, but you should take adequate measures to sort of elevate the chest slightly more compared to the standard supine position. The reason is that you want to utilize the maximum length of the intercostal. In any nerve transfer procedure, you should remember that if you end up putting a graft in between, then the whole purpose is defeated. The very fact that the nerve transfer procedures are done so that the anastomotic site is only single. Because if you end up with two anastomotic sites, then you will lose a lot of axons in that anastomosis and the outcome may not be good. So in a nerve transfer procedure, the anastomosis should be direct. Then only the anastomosis is good. Otherwise, there is no point in doing a double anastomotic grafting in a nerve transfer procedure. So for that, always the length of the nerve should be adequate to anastomose it without any undue tension and all. Especially in this intercostal anastomosis, this principle should be very importantly followed, because at the end of the day, patient is going to abduct his arm. And if the nerve is anastomosed under tension, moment he will start doing it, the anastomosis will give way. So that the anastomosis should be absolutely lax. Plus the position, while giving position, the arm should be abducted on the table itself, So, and you do the anastomosis in an abducted arm position. Then only the purpose is solved. Otherwise, if you do the anastomosis in an adducted arm position, you will end up losing out the anastomosis. So that is very critical. And plus the trunk should be slightly elevated so that you can harvest the nerve right up to the the lateral part of the chest, so that you get an adequate length to bring it to the axilla, so that the anastomosis is lax. So this is very critical. So this is, the arm is totally abducted almost up to the 90-degree, and then we anastomose it so that when the patient is abducting the arm, there is no pressure on or stress on the anastomosis. And generally 3 nerves are used. 2 would be a little bit inadequate because the axons numbers are in the intercostal nerve are hardly between 1200 to 1500 in one intercostal nerve. And to cover the surface area of the musculocutaneous nerve, you need 3 intercostal to cover that surface area. So 3 intercostal nerves are preferred, preferably the 3rd, 4th and 5th intercostal nerve. And you can co-opt it with the intercostal, with the musculocutaneous nerve, so that you get a good outcome. So this is the video, just short, but this is done under microscope, so you may not be that much oriented, get oriented when you see that, but I think in cadaver you may be better able to appreciate it. So the first step is to identify the musculocutaneous nerve, as we already discussed in the Oberlin procedure, that go under the bicep belly, identify the musculocutaneous nerve, and then dissect the nerve right up to the point where the nerve is bifurcating from the lateral cord. Go right up to that. You try to retract the coracobrachialis muscle and try to go as high as possible so that you get adequate length of the nerve to mobilize it into the axilla. That is very critical. Otherwise, if you don't do proper superior dissection, you will not be able to bring the nerve to the axilla, and then you will fall short of anastomosis. So the musculocutaneous nerve should be mobilized adequately so that you get adequate length. And I said in few cases now, I have done internal neurolysis and separated the lateral cutaneous branch from the musculocutaneous so that we anastomose only the motor segment of the musculocutaneous nerve. But there is a little bit of doubt in my mind as well that you may be devascularizing the musculocutaneous nerve to some extent. So we'll have to wait and see the outcome. So this is the musculocutaneous nerve which is identified underneath the bicep belly. You can see medially the median nerve. And then go on dissecting this musculocutaneous nerve superiorly to the end where it is coming out from the lateral cord. You can see how much length of the nerve we need to mobilize it before we feel enough length is mobilized, I'll just a little bit go forward. So we have mobilized enough musculocutaneous right up to the coracobrachialis muscle. You retract it and mobilize the nerve. And this retractor is positioned here so that you can see a little bit more inside. In fact, this maneuver was taught to me, told to me by Professor V.S. Mehta, that you go as high as possible till the bifurcation. He used to regularly say that to mobilize the nerve, you should go right high up. So once you have done that, the musculocutaneous is mobilized. And then you can just put your finger to feel the lateral cord, and then we can say that we have mobilized right high up for an adequate distance. So then we come to the intercostal nerve harvesting. So you take that incision, you raise the flap and then identify the ribs over there. And you take all the muscles in one flap so that you don't denervate those muscles. And then once you reach the rib, it is at the lower border of the rib where these intercostal nerves are. and you have to do a subperiosteal dissection. I think I've gone a little bit more forward. So this is the exposure which generally is done. And this is the rib which is exposed, and then you go subperiosteally along the lower margin of the rib. And do this subperiosteal dissection. There would be the intercostal nerve as well as the artery. Sometimes there can be some bleeding from the artery, but don't coagulate it, because if you attempt to coagulate, you will coagulate the nerve as well. Just sit tight and don't do any coagulation, man. It will stop on its own. And then this subperiosteal dissection is done. So once you do that, then you will expose the intercostal nerve. It's a very thin nerve, and go right up to almost midline, so that you get adequate length of the nerve. And then simultaneously, as I said, that go along the lateral aspect of the chest wall also, so that you get adequate length of the nerve to mobilize. The main problem is that to gain the length is of the lower intercostal nerve, the fourth and the fifth, especially the fifth, because it has to travel a lot of distance to come into the axilla. So that nerve should be adequately mobilized to have good adequate distance. Avoid using cautery in this region or any coagulation, because you can inadvertently injure the nerve. And as you can see, when you do that, you can see the nerve. The nerve just sits on the pleura. You can see this now. So then when you identify the nerve, just loop it with the loop and then go on dissecting it till the midline. I'll just fast forward it. It's a little bit tedious job to do it, but then at the end of the day, you have to do it. Is it okay? I continue or move fast forward? So these nerves are in that way, all the three nerves are mobilized.
How literally do you mobilize it? Till the anterior axillary line, middle axillary?
Yeah, a middle axillary line, almost up to the mid axillary line. So that is why I keep some sandbag or some sort of a cushion underneath the chest wall so that we elevate. Because if you keep it straight, then it becomes very difficult to mobilize it. So while putting that, you put the body slightly elevated.
So you cut first and then keep mobilizing it?
No, I mobilize it and then cut last.
How much pressure we put on the nerve, because it looks like very sturdy?
Generally, if you take adequate precaution, generally it doesn't rupture, but it should not be very violent. I generally do in the mid and then identify and go medial.
In the
and
middle
lateral.
is very easy to access.
Because here
very
laterally
available.
there would be a lot of muscles, and also to go through that and identify may sometimes become difficult. It all depends on what is the bulk of the patient. Sometimes the heavy patients, it becomes really very tough to go directly in the mid axillary line. So better to be here where the nerve. Yeah, but those which are running into the muscles, the adequate length is not there, so you have to use this only.
From distal to proximal.
Not mid, I generally do it at the around mid chest and then mobilize on the either side.
So rest of the delegates, like, stay tuned. Abhishek.
that when we connect to the muscle, we have to tunnel it.
No, there's no need. We have, as I showed the previous video, we take a continuous incision and just, yeah, no.
In the axillary fold.
Yeah, but that I remain on the superior aspect of that. Yeah, on top of it.
We sometimes just tunnel it through.
No, as I say, see here, I'm cutting it now. Because it becomes slightly blind, and you end up pulling the nerve and all. What you said, I am just cutting it and making it a one incision.
Yeah. So rest of the delegate also, if you have any questions.
So here,
please
this is cut like that, so that that elevated the junction is obliterated, and the nerve becomes at one plane. So this is how the anastomosis is done.
This is the reason I asked the question previously when we doing under to brachialis and brachialis, that why can't we directly do the muscle? Because intercostal we are directly doing the muscle without really. I don't differentiate between sensory.
Yeah, but here we are utilizing 3 nerves. So
more axons.
More
there, so
axons.
that there is no
that-
precision.
There is only one fascicle. So here, this is the 3 anastomosis. The 3 nerve anastomosis to the musculocutaneous is done. Yeah, I sutured it, and then I don't take direct glue because it may just give way.
Again, any preference for medial part or posterior and lateral part for musculocutaneous or?
No,
general?
the whole nerve, but
Whole
as I
nerve,
said
but-
before to him that now since last few surgeries I'm mobilizing the nerve and eliminating the cutaneous branch, cutaneous component. So I'm taking sutures. So the one method which is practiced in long time, there are a lot of surgeons where I trained also, my boss used to do it. What he used to do is to co-opt the 3 intercostal nerve with the glue in one piece, and then anastomose with the musculocutaneous nerve. But sometimes, that may also sometimes, may not be adequate strength in that anastomosis. So generally I prefer to anastomose individual nerve to the musculocutaneous and then put a glue.
That we put glue, the glue will go between the coaptation.
But the glue generally get absorbed in some 4-6 weeks time, so generally should not be a problem. Yeah. So you can see the 3 nerve has the adequate covering of the musculocutaneous nerve. This 3 nerves, and then put a glue around that.
How many sutures we should put?
At least one tag. You cannot put more sutures because the nerves are very thin. At least one suture of the intercostal to the musculocutaneous is at least should be there. Okay. Now I don't. Around 2 hours, 2.5 hours, I generally manage to do it. As you go on doing it, previously I also used to do it. As I said before, also this is the most tedious operation of the brachial plexus.
It's beginners, it is a very tedious, but as soon as you do it, then it's just become a very easy.
Around
just
2.5
mobilize
hours,
and
I
do it.
managed to do it.
For resting a single intercostal nerve, it takes at least 40-45 minutes.
No, if you remain in the plane, you can in 5 minutes you can do it. Nothing much.
Previously, when I started, the intercostal nerve identification is a little tricky when you start. So for the beginners, I can say what I used to do. I used to use a B1 and undercut the
So that is
lower part of the
that is what happened when I started doing in KEM to begin with, because when I did the fellowship, this approach was not done. So it was a new to me. This was in 2000. So I used to call the cardiac surgeon and to harvest the nerve. And the method in which he was harvesting, I felt that we are much better than them, because they used to just clip the ribs and remove the rib and show the nerve to me that this is your nerve.
But using B1, you can cut the inferior little bit of the rib. So nerve becomes very beautifully. So once you do 3-4 cases, then you exactly know where the nerve is. So then you don't need to cut.
Sometimes you may end up opening pleura also, but don't worry, nothing happens.
Nothing
you
happens.
can just.
Dr. Praveen,
Any comment, Praveen?
Yes, sir. So, as you are telling, it is very depressing to see the nerve first time. You have put such a big incision, and when you see the nerve,
Yeah.
it's like, what is this?
Why, whether it's what doing it?
Yeah, for this all big thing for that. But once 3 are taken, I think it fits well. One thing which helps is, again, is you're telling cardiac orthopedic surgeons, one technique is there. Can make one drill hole in the rib and then take the bone hook to lift the rib up.
So I do that, Praveen. I tell my assistant to lift the rib so that we see the nerve. Sometimes the nerve is underneath the rib, and
Under the rib, yes.
sometimes find it difficult, especially cases where there is a chest trauma and there is some degree of fibrosis there. Then the identification of ribs does now become difficult.
Yes. So if the rib is lifted, then it becomes easy. So here again, the assistant will be cursing all the
Yes.
time because his main work is to pull it up. So that way it will be helpful.
Yeah, all surgery is under GA. You will not allowed to touch the nerve.
GA with no relaxant. GA with no relaxant because you need to stimulate, no? It is actually proved to be safe. It is proved that it does not cause any problem taking 3 intercostals. In fact, there is a group which does intercostal
And phrenic, both.
together same time. And they also say that phrenic and intercostals are activated by different maneuvers. So they would do intercostals to bicep and phrenic to triceps. It's telling like one is the inspiration muscle, other one is expiration, so there won't be co-contraction. So, but we don't do. If phrenic is not working, we'll not.
Global palsy, we usually don't do anything for the hand. We usually do for the shoulder and.
So that is where their role is.
How can we
He will show in this. We'll see, sir. That is in the next talk.
Next talk and tomorrow.
Tomorrow.
Thank you, Dr. Ketan.
Yeah.
How much distally do you move? Proximity to mid-extreme, like how much distally?
I said no, up to the midpoint, the midline.
Midline is the maximum.
Yeah, for at least 4 weeks we keep the arm in the box and then they can do it because we have done the anastomosis in completely 90 degree. Yeah. But we instruct them not to lift the arm for at least 4 to 5 weeks. Then they can gradually start. When the time of discharge, I tell the physiotherapist there, lift the arm. While very close also, we instruct the patient at home, lift the arm and wear the clothes.
कोई और है भेज दो he has to go down start immediately.
Dr. Ketan will go down, cadaver start the dissection so that he can start showing as soon as Dr. Praveen stops his talks.
Okay. Now I'm going to talk about 3 nerve transfers. One is the triceps to axillary for improving the deltoid function. The second one, fascicle transfer to the motor branch of the triceps to improve elbow extension. And third one is a pronator quadratus to ECRB for restoring wrist extension. They all are a little bit intermixed, interconnected, so all 3 will be finished in this session. So the long head of triceps branch to the axillary nerve transfer is the one which is called as the Somsack transfer. So generally we call people by the second names, but this second name here is very difficult, so that's why it is called Somsack transfer only. So it is Lingcho 1 transfer. So that is, so even Somsack has agreed that you can call me as Somsack. So this transfer transfers a long head of triceps motor branch to the anterior division of axillary nerve. This is the picture from the original article which was published in 2003. So Somsack used the long head branch thinking that it is closest to the axillary nerve and it is discrete of all the branches of the radial nerve going to the triceps. So here nice thing to remember is the triceps, which has 3 heads, has got independent innervation of all the 3 heads. So that means each head could be trained to do an independent function. And that is the basis of doing the nerve transfer or isolated long head tendon transfer. So it can work quite effectively, and patient does not have to do elbow extension to do the abduction. They can learn it quite quickly. This is a line diagram which shows that this is the long head branch to the triceps. The radial nerve coming at the lower border of the teres major. The first branch comes out is the long head branch. Then it goes down and gives the medial and the lateral head branches. The lateral head has multiple branches. The medial head has a long branch which goes eventually and supplies the medial part of the medial head of the triceps. The long head is divided distally, flipped around and attached to the axillary nerve. And in their procedure, they recommended to attach to the anterior division of the axillary nerve, mainly for 2 reasons. One is the long head branch is not very big. It doesn't fit the whole axillary nerve. So it matches nicely with the anterior division alone. Second thing is their dissection revealed that anterior division supplies the anterior and middle part always, and in 70% the posterior part also. And since the posterior division of the axillary nerve has a thick sensory component, you may be wasting your axons. So that is the reason why they attached only to the anterior part. Now this is a small video of the procedure where we do by posterior approach, but patient is supine. So we put the hand on the chest like this and then do the procedure. So it is a posterior approach but done in supine position. That is the position of the hand. Now this area is exposed quite well and it is not difficult to do. No, there is no need to make the patient prone. The incision is over the posterior border of the deltoid and a curved incision, and at the lower border of the deltoid it goes to the midline then. So it is a kind of this V type of incision going to the midline of the arm distally and proximally at the posterior border of the deltoid. Then you dissect onto the posterior border of the deltoid and dissect the muscle till its maximum depth. At that point you would see a sensory branch coming out there, and this sensory branch is the one which is coming from the posterior division of the axillary nerve. This is one way of reaching to the axillary nerve. So this branch which I have hooked in here, that is the sensory branch coming from the posterior division of the axillary nerve. So one way to reach to the axillary nerve is dissect it, go more proximally, you will be able to reach to the axillary nerve. Another way is more anatomical, you go to the radial nerve, come to the teres major and then come more proximally. But generally we can use the both the techniques and come to a correct easy access to the axillary nerve. Now we move on to the distal part of the exposure, where we want to find the interval between the long head and the lateral head. So it is a very subtle interval, not very clearly defined, but if we see carefully there is a slight difference in the color of the 2 heads. Because the long head has got a thicker fascia, it will look little bit more darker, but the lateral head does not have fascia, it will look a nice bright red. If we are able to find that gap clearly, then our half work is done there. And then it is a nice internervous plane between the two. Just with a blunt dissection itself, we can reach to the radial nerve. That yellow thing shining in the depth is the radial nerve there. So it is quite easy to access this way. But suppose we are not able to find the 2 heads, then we need to go more proximally and then come down distally again. So once you go proximal to the radial nerve, this white shining thing is the tendon of the teres major. That is the main lighthouse in this area, because it will give a guide to the radial nerve branches and also to the branches of the axillary nerve. The branch of the radial nerve just distal to the teres major is the long head branch. This is the long head branch. It is always discrete, easy to identify, and there is no confusion in that at all. And it is also close to the axillary nerve. That's why probably Somsek felt that this is the best transfer to do. Distally, you can identify again a separate branch which lies more posterior. This is the medial head branch. So we can easily separate that out and loop it and keep it for a nerve transfer later. Also interesting to see medially, this is the ulnar nerve. It is surprisingly very close to the radial nerve in this area. So some patients where you want to innervate the triceps with the ulnar nerve, we could do by the posterior approach also. And we should not get confused with the ulnar nerve and the long head branch because they are quite close to each other. So always stimulate and confirm. Now going to the axillary nerve, which lies on the upper border of the teres major. So this is the teres major, that was the tendon, this is the muscle. You retract the teres major down and then you would have this axillary nerve in the quadrangular space. It will be covered with the fascia. We can dissect and take it out. Generally, we will have the anterior and posterior division separately, already divided at this level. And it can be confirmed as posterior anterior by pulling onto the sensory part. You can see after pulling the posterior part, the remaining one is the anterior part. So that way we can differentiate between the anterior and posterior division. Other things are the anterior is bigger. So we go in the maximum depth possible, clip the nerve because sometimes it may start oozing in the depth otherwise. Clip the nerve, cut it as distal as possible so that you, again the same principle, the recipient is going, donor is as distal, recipient as proximal as possible. We get a very good length of the axillary nerve now. It will very comfortably reach to any of the branches of the triceps, whatever we decide to. And then we concentrate on choosing the medial or the long head branch. So how to choose? You can stimulate and confirm. So we generally prefer the medial head branch for two reasons mainly. One is because the long head branch also adds to stability of the shoulder, so it is better to keep it intact and use the medial head. But if the long head is working better, then we take the long head. And once here we have used the medial head, once it is divided, it comes out quite comfortably, very good length, and we can get a perfect coaptation. On the first look, it will appear as if the nerves are very mismatching. The axillary nerve is very thick. But we should remember that axillary nerve has got a much more non-neural tissue. So once we have excised the non-neural tissue, you will see that the coaptation would come quite nice. So it will be only like 100%, that kind of mismatch, not like 50 and 100. So once the non-neural tissue is dissected out, this medial head branch almost nicely matches to the anterior division of the axillary nerve. So these are the steps for the posterior approach. Same Somsek operation, that is the triceps to the axillary nerve, can be done by anterior approach also. This is called as the axillary approach. This is the incision of the axillary approach, and this is the dissection. So here we take the median nerve, the brachial artery, retract them laterally. Down in the depth, we would see the ulnar nerve here, that is the brachial artery, and down, that is the radial nerve. And once all the things are lifted up, this is the teres major, and down in that quadrangular space would be the axillary nerve. So this can be done with the same incision that you are doing an Oberlin transfer. There is no need to go into the posterior incision. But here the access is possible only to the long head. So triceps must be totally normal. If there is slight doubt on the tricep power, then it is better to go by the posterior approach. And here again, the axillary nerve can be hooked quite easily. This is the axillary nerve, and we can do our coaptation. So on exploration from the anterior side, again the teres major is a main landmark. The axillary nerve lies above the teres major, and the triceps motor branch lies at the lower border of the teres major. So we identify the radial nerve. From the radial nerve, the branch which is coming at the level of lower border of teres major is the triceps motor branch. So again, the axillary nerve is divided in the depth there, flipped down and attached to the long head of triceps motor branch. The cooptation comes quite nice by the anterior approach also, but we can do only the long head transfer in them. So same exposure where you are expose the long head branch, as we saw over here, long head of triceps. If the triceps is not working, we can take a fascicle from the ulnar nerve and do a nerve transfer to this long head of triceps to get elbow extension. So this was one of our paper where we restored elbow extension by using a fascicle of the ulnar nerve. The paralysis of posterior cord is very uncommon, but if it is present, this is a good nerve transfer to do. The exposure is the same. You have to identify the long head triceps branch. The ulnar nerve, one fascicle nicely matches to that branch. This is the scheme of the transfer, one fascicle of the ulnar nerve taken and attached to the long head branch, something like that. This is the long head branch. It is flipped proximally, brought here, and ulnar nerve fascicle goes on to that. This is the transfer, and this is the kind of result it can give. The long head alone, if recovers grade 3, patient will be able to do an anti-gravity elbow extension, and they will be functionally quite comfortable. For more details, you can refer to this article. Now coming to the last of the nerve transfers for today.
One question.
Yes, sir.
So suppose a patient has, we want to do Oberlins also.
Yes, sir.
And he has posterior palsy in the sense that he's not able to extend the elbow.
Yes, sir.
Can we can take 2 fascicles of the ulna? How many fascicles can we, basic question, how many fascicles
Yes,
can
sir.
we take?
Sir, once we had taken 2 fascicles, one at higher level, one at lower level. But while telling that, one senior nerve surgeon told me, you should not tell this in meetings because it is a little risky. So he told, if you tell me, everyone will think it is okay to do, but it is not correct to do because for 2 reasons. One is you can cause palsy. Second thing is we may have taken the same fascicle which we have taken higher up. That is the thing, sir. So suppose we want to innervate both, we can take median nerve and put to the biceps and put this ulnar fascicle to the triceps. But there a small risk is there, sir, because both of them will recover at the same time. So training becomes a little bit difficult. So suppose we have this type of situation, we generally will put intercostal to triceps because that will take anyway long time. Let our biceps come first and the intercostal comes, the triceps will recover later. So we should not do both nerve transfer where biceps, triceps come at same time. That was the small things. Any other questions on this nerve transfer for elbow extension, axillary nerve? Sir, anterior simpler, sir. Anterior simpler in the same incision, but it is possible only when all the heads of the triceps are working. Because from anterior, we are not able to confirm the functionality of the medial head and lateral head. So in case it was only long head working, the patient will then lose the elbow extension. So safe is posterior so that we can see all the things and plan comfortably. And again, going by that principle of reaching closer to the muscle, posterior is better. Because other thing what happens when the axillary nerve is coming through the quadrangular space, that is also one potential area where it could have got injured. So if we do by anterior approach, we are missing that injury. So shoulder palsy, we always go by the posterior approach.
And on NCV, can we find out for all the 3 heads individually?
Sir, NCV they are able to tell, EMG people are able to tell whether all heads are working. But clinically also it is quite okay to, because medial head is quite discrete only, we can palpate the medial head correctly. Any questions?
Do you always add Oberlin 1 and 2 the Somsa procedure in partial injuries?
Yes, sir. We always try to put, in case the triceps is functioning well, we will always do the transfer to the axillary nerve.
Yes. Yes, axillary nerve. So generally patients we are telling 6 months for elbow bending, 1 year for shoulder lifting. But at 6 months we can start seeing good contraction. But overhead lifting they will take almost 9 months to 12 months. Medial pectoral to axillary nerve also one option is there when the triceps is weak. We have not done that. It is, but the people who have reported, they say it is quite a good result. Medial pectoral we have not done. Yes. So now this nerve. So this is the nerve transfer for restoring wrist extension. So wrist extension restoration can be done by tendon transfers. So we know that radial nerve palsy patients also have wrist drop, and tendon transfers have been done for years and everything is working nicely. So whenever there is a debate between nerve and tendon transfer, the radial nerve is the only place where tendon transfer may win the debate because it will almost never fail. But here in brachial plexus injuries, the patient profile is little bit different. And that's why the nerve transfers may start winning. Because a brachial plexus patient, because of the C7 involvement, there the donor tendons which are used for tendon transfer may not be functioning. We know that C7 gives in power to the pronator teres and also to the FCR. So a patient with extended plexus palsy where the wrist is dropped, he is very different from a radial nerve palsy because the FCR is not working, the pronator teres is not working, and these are the two main tendon transfers which we are using for radial nerve palsy. So that is the reason why the nerve transfer is a good thing to do in a brachial plexus patient. And one of the nerve transfer which is useful to restore wrist extension is to use the terminal part of anterior interosseous nerve which is supplying the pronator quadratus and transfer it to the ECRB motor branch. So you can get a wrist extension. Then you will remain only for the finger extension. For that FDS can be used. So that's why that reason it nicely fills up that gap of doing a tendon and the nerve surgery for these extended plexus patients. So this is the scheme of the transfer. The anterior interosseous nerve as it comes down, the pronator quadratus is the last muscle which it supplies. And the muscle which it supplies before that is the FPL, which is much proximal. It is at the junction of the middle third and the distal third forearm at the lower border of the pronator teres. So that means from here till here, this much of length of the anterior interosseous nerve is available, and it is a nice perfect motor branch which is going only to pronator quadratus and can be used to innervate any of the paralyzed muscle. So this nerve is cut as distal as possible, flipped around and attached to the ECRB motor branch. So that way it can restore our wrist extension. And this is the scheme of the transfer. And now a small video. Whether the anterior interosseous is working or not would be basically doing the exploration. So incision is on the yes. The volume band करो. वॉल्यूम बंद कर दी नहीं इसका वॉल्यूम वीडियो का. So this was almost 1 hour video, so I have edited, so volume would look very distorted. So this is the incision right from the distal third of the forearm going till the proximal third of the forearm at the level of the elbow joint. So almost the whole forearm is affected. Whole of the forearm will be explored.
This volume clear.
Interosseous nerve would be identified between the tendon of the FPL. In this case, already pronator teres is not working. You can
Here it is not coming that volume. Okay, okay. Yes, sir. Okay. Yeah, हो गया ठीक है ठीक. So this is the incision to start with. And the distal part will be used for harvesting the anterior interosseous nerve and the proximal part for harvesting the ECRB motor branch. So basically we want to reach in the pronator quadratus is the deepest of all the muscles. So we go in the interval between the FPL laterally and the FDPs medially. And once you reach in that depth, you will see this anterior interosseous nerve along with the anterior interosseous artery, which goes into the pronator quadratus and disappears underneath. The nerve is confirmed to be working by stimulation. It will cause a slight pronation like that. And then our dissection moves proximally. Here we want to identify the ECRB motor branch. So this laterally is the brachioradialis and medially is the ECRL. This is the sensory branch of the radial nerve. This is our main landmark to identify the ECRB motor branch. Once this sensory branch of radial nerve is identified, we dissect it proximally. We try to go as high as possible. And then we will start seeing in the depth the ECRB motor branch. ECRB motor branch is the nerve which is in the deeper plane but same line as the sensory branch of the radial nerve. This is the ECRB motor branch. We can see it comes in the same line as the sensory radial nerve but is in the deeper plane. That muscle nerve in the depth is the posterior interosseous nerve. This is the ECRB motor branch. This is the sensory branch of the radial nerve. So that is the trifurcation of the radial nerve, what we have seen there. Our interest is in the ECRB motor branch. We stimulate and confirm that it is not functioning and then divide it as proximal as possible so that we get a good length of it. And once it is flipped down, it will reach almost till the mid-arm level at place where our anterior interosseous will actually come quite comfortably. So we have a good length of ECRB motor branch. We can see it is entering in the ECRB there. Now we switch our attention to the anterior interosseous nerve again. The nerve is dissected. It will have an anterior interosseous artery coming along. So this is a bit of tedious dissection. Very carefully we need to do so that there is not unnecessary ooze over there. This patient, the surgery is being done under tourniquet, so it may look like much neater, but sometimes when you are doing only with infiltration, there may be some more ooze around here and there. We remove some part of the pronator quadratus so that we can get an extra 1-2 centimeter of length, though most often you will not require that length. Once the nerve is cut, it is dissected proximally to get the full maximum length of this anterior interosseous nerve. This whole nerve is a functioning nerve, so it is a good transfer to do because you will get a good length of the functioning nerve. The nerve is mobilized till you reach to the level where you see the FPL motor branch. So FPL motor branch comes at the lower border of the pronator teres. So in this proximal part, once we dissect, in this corner we would start seeing this is the FPL motor branch. So once we start seeing that branch, you don't dissect anything proximal to that because we don't want to paralyze the FPL. Then we make a tunnel under the muscles, and through this tunnel we will reach to the proximal part where we have the ECRB motor branch. This tunnel can be quite spacious so that our nerve is not tight over there. It is easy to make this tunnel from distal to proximal, and then you do some railroading, come over there and bring the anterior interosseous onto the proximal wound. So something like that. That part what we have taken through the pronator quadratus is actually very useful to do all this holding of the nerve, because we don't want to hold the nerve and then use that same thing for the repair. And we can see here once it is tunneled onto the proximal site, the length is quite sufficient. It comes so easily. There is a lot of overlap always. You will never fall short of length. And once we have good length, then you excise the part which is belonging to the ECRB so that you can reach as close as possible to your repair site. We too, like Ketan sir, put sutures always. So generally we'll put 2 sutures 180 degrees to each other, and this is one technique which we commonly use called as outside in technique, by which you can nicely evert the non-neural tissue and get good approximation of the neural tissue. And 2 sutures generally, and then usually we will augment with some glue also. We should not put too many sutures, especially if the nerves are of good size match. Generally 2 sutures are enough. And it is always good to do this nerve coaptation under microscopic examination. Many times we feel like the nerve is coming okay, we can just feel like put in the loop itself, but it is not good. Once you see in the microscope, you will realize that what you are doing without seeing it under microscope was actually not nice. So once we put this outside in 2 sutures, you will see that the nerve actually approximates quite well and you will get a good apposition. And this can be augmented by glue, 2 drops of glue over there. There is no need to put too many sutures. We should also resist the tendency to suture it very tightly. It should come like a nice nerve holding together, and to do under microscope always. Thank you so much. Any questions on that?
I think it's a good procedure.
Yes, sir.
We should use it more often. We don't do it too much. But for wrist extension, I think it's excellent.
It is good, sir. So distal transfers, theoretically, they can be done almost till 1 year, because you are within 1 or 2 inch from the muscle. But all the studies where good number of cases are there, again the results are good when it is done within 6 months. So, but 6 months is quite good range. Yes, sir. This also very short. It is very close. Very close. It would actually give the same result as late Oberlin. So though it works, but again the success rate is little bit lesser. No, when we do before 6 months, we can almost tell 95% it will come. But when we are doing at 1 year, 70, 75, and that power is not that good. So rehabilitation protocol in general, we keep the patient totally rested for 1 month, and after 1 month we start them stimulation of the muscle, direct muscle stimulation. So that is done till the nerve starts working. After the nerve will start working, then the stimulation is stopped and patient is asked to do active movements only. So that is the general protocol what we do. And this wrist extension transfer is a nice transfer to do, especially one group of patient where we need to be carefully. Some patients may look like they are doing wrist extension, but they may be using the finger extensors to extend the wrist. They do like this. So these patients, we may think his wrist is okay, but once we do the Oberlin hand recovers, whenever they hold anything, the wrist falls down. So they not be using the hand properly. So the good way to check true wrist extension is you give something in the hand and ask to extend the wrist. If they are not able to extend, then 100% the ECRB is not working, and we can add this. Lymphedema. Okay. We have not faced any problem with for lymphedema for these patients. We have not. Okay. Because we are not excising all the lymph nodes and all in the axilla. We are not excising. Yeah. Yeah.
Lymph nodes not removing.
Yeah, and don't damage the vein.
So Ethan sir had shown that that cut is only, we are going only till the subcutaneous plane. You are not excising all the things in the axilla. It is okay. Finger extension in brachial plexus patients, we are not having a good donor for finger extension. So that we will go for a tendon transfer. So if the FCU and palmaris longus are working, we can leave the palmaris longus there and use the FCU for finger extensors. But if they both are not working, then we should use FDS for finger extensor. Yes, sir. Nerve transfer not good because FDS also is not normal. Yes, sir. So pen plexus, basically 4 options are there, sir. One is the phrenic, next one is the intercostal, the third one is spinal accessory to musculocutaneous, then the fourth one is the contralateral C7. Yes.
Nothing beyond that.
Beyond that is pre-functioning muscle transfer for fingers, FFMTA. That is the next level.
So next we shall start with the master demonstration.
So we are on. Hello. Hello. Can you hear? Hello. Hello. Yes, sir. Can you hear? Hello.
We can hear you, sir.
Okay. So just because of the shortage of time, what I have done is that I have just put the incision. Can you see the view?
No. Audiovisual, please show the cadaver view, microscope view.
They are bringing in the camera. Just wait for some time.
Yeah. We are tuned. Yeah. Delegates, if you have any queries, keep asking. There can be a repetition, but clarification of all doubts is important for next 2 days.
This is the overhead. इसको मेरा काट डालना
We will try to finish this master session by 1:30 so that you can quickly have lunch and then join your hands on.
एक सूचर ले ले इधर एक वन सूचर ले ये कितना नंबर है 20.
बोलो देना ना. कुछ नहीं करके न्यूरोलॉजी को बोला था ना, एफपीडी नहीं कराया था. अगर हमारी तरफ से वो सीटी स्कैन में कोई डिफरेंस नहीं है, तो रूल्स नहीं है, तो रेफर टू न्यूरोलॉजी का फर्दर मैनेजमेंट करके रखा था.
क्या उनको दिखाने के लिए क्या? नहीं, उसको बड़ा काटना, बड़ा काट बस. चलो.
Dr. Ketan, we are there with you.
Yeah, but is the camera on?
Yes, camera we can see nice.
Okay. Now see, I have taken an incision. Since we are doing this cadaver dissection, I have taken a lazy L incision.
So this is on the which side?
This is on the left side.
Left side.
And I will roll the delegate.
Ah.
This is the superior aspect. This is the ear.
Right.
And this is the inframandibular point.
Right.
Okay. This
Right.
is the sternomastoid muscle.
Okay.
The medially, the black mark is the clavicle.
Right.
Okay. So this flap which I had taken lazy L, I have reflected out.
Right.
Just taken one anchor suture to keep it in position. And now, if you can see, once I lifted the skin and platysma here in the cadaver, it's now very difficult to dissect the platysma from the skin subcutaneous.
Yes,
because of
true.
the
Very true.
changes. So I reflected whole flap.
Correct.
And this is the vein which I have dissected out.
Right.
This is the vein, the external jugular vein. Can you see?
Yes.
This is the external jugular vein, which had some tributaries going on the lateral aspect also, but that I have cut. But this is the main one which is going into the subclavian vein. As you can see, it's going medially.
Right.
Yeah.
Right.
This is the so this is the external jugular vein which I have reflected. Now this is the portion of the clavicular head of the sternomastoid. Still some portion is there. I'll reflect out.
Right.
The whole muscle we have to reflect out so that we can see the brachial plexus properly. You can easily separate that muscle bulk with the finger, during surgery.
Okay.
So this is reflected out.
Yes.
And then if you can see here, this is the omohyoid muscle which is there, the tendon here. You can see here. I've taken one suture to just keep as a landmark, identifying landmark. This is the omohyoid belly.
Yes.
Okay. And these are the few tributaries of the jugular vein, external jugular vein going laterally here. And during surgery, you have to take care of all these veins. At present, I'm just removing it off. And this is the transverse cervical artery, which I have dissected out.
Okay.
Okay. So once you do that, any question up till now?
No, it is very clear.
Hello?
Yes, it is clear, sir.
No, any question?
No questions.
So all the landmarks and points which we needed, which we discussed during the dissection. So these are the various steps of it.
Right.
Raising the flap.
Right.
Then identifying the jugular vein, external jugular vein.
Right.
Then identifying the omohyoid muscle, identifying the clavicular head of the sternomastoid. And then there is this this is a transverse cervical, identifying the supraclavicular fat, as you can see over here.
Right, right.
The supraclavicular fat.
It is very clear. Any questions, anybody?
We'll lift the fat as much as possible. Let us see how we can.
So fat is dissected from lateral to medial, medial to lateral, sir? What?
Generally, I do it inferior and medial to lateral, but here, because of the cadaver, whatever we can do it, we can. Do it very gently whenever you do the dissection here in cadaver. Otherwise, you will just miss some structures.
Correct.
So the moment you do that, you are exposing the brachial plexus. You remove the fat. You can see the brachial plexus?
Yes, we can see.
Hello?
Yes, yes, we can see.
So this is the brachial plexus. Retractor करेंगे. Because of the rigor mortis and all, sometimes it may be a little bit difficult. But you can see here the
nicely seen.
Plain forceps. While going near the thing, I would recommend use the plain forceps rather than tooth one. Okay, ठीक है. तो ये लगाओ, tape लगाओ, tape. So we'll sling it with the tape.
Okay.
लगाओ, artery लगाओ, नहीं ये तरफ मेरी तरफ से. So then once you do, this is the upper trunk of the brachial plexus.
Right.
And then we'll go superiorly to identify the roots. So this is the C5. Tape लगाओ. इसको आधा काट दो. So as you can see, what I was talking, that the arrangement is oblique.
Right.
First we see is the upper trunk, and then medially we would see the C7 roots and the middle trunk. So this is the C5. The C6 is a little bit larger one.
Right.
This is the C6. Artery level. Just keep some artery over here. So this is the C6 which I have looped, and then we follow it a little bit distally. Now we'll need, once we have identified, I think we'll need to cut this, otherwise it will come in our way. So we'll just cut this artery and the omohyoid. All have seen these structures, the artery and the omohyoid? Hello?
Yes, yes, I think we are clear.
These are the two structures, so we'll need to cut it to expose it down because this is a cadaver thing, so
yes,
quite stiff. You can see here this tributary of the jugular vein also here. This is very important, during surgery this bleeds invariably, so you have to take it before you cut it. Otherwise it will unnecessarily bleed here, this lateral tributary of the external jugular. Cut off. रिट्रैक्ट करो. ये भी करो.
ट्रांसफर
This is the phrenic now. This one is the phrenic one. Can you see it?
Yes, yes, we can.
On the scalene anterior. Entering here. So now we'll identify the suprascapular. Probably this is the suprascapular.
Yes, it looks like
place
it.
it distally to check it. So it's going lateral.
Yeah.
हाँ ये रूट्स है ना. Oh, yeah, the injury, though, they're all pulled down, so there is no specific landmark. It all depends on how much is the stretch injury. So this is the upper trunk from which the suprascapular is arising.
Right.
And we'll have to just dissect it in underneath the clavicle to identify the divisions. इधर retract करेंगे clavicle. Any question if you have, just keep on asking.
Right, Dr. Jason. We can see everything very nicely. Yes, yes. At 9 o'clock we have the head.
This is the subclavius branch.
Right.
From the upper trunk. Yeah, sorry, Deepak, what?
So the audience wanted orientation again. Some of
Audience wanted what?
Orientation of
Yeah, so this is at this location, this is the medial aspect of the posterior triangle, medial and inferior, just above the clavicle, where the external jugular vein is going and joining the subclavian vein. This is the medial margin of the lateral margin of the scalenus anticus, which is retracted. And this is the suprascapular nerve. This is the clavicle and the suprascapular nerve. See, mind you, this is not a injured patient. So the suprascapular is quite at the normal location, about 1.5 centimeter above the clavicle here. When we operate, generally it's quite low. But here it is at a normal location here. This one. That we can follow it in the. I think that exercise that the candidates can go on doing it to trace the nerve
that they
beneath
can
the
do.
clavicle. I'm not going it. Now we have identified the upper trunk. And see if we can identify the divisions of the. So there is this divisions of the upper trunk.
Right.
So this is the posterior. This is the anterior. Okay.
Right. Again.
Yeah. Another sling. These are the two divisions of the upper trunk.
Nicely seen.
Here. Okay.
Right.
This is the upper trunk, the suprascapular nerve.
Yes.
The subclavius branch.
Right.
And these are the two roots, the C5 and C6.
Right.
So this upper trunk is and the roots are exposed. Now we'll try to see whether we can expose the C7. Retractor बरोबर करना पड़ेगा because stiff है सब. This is the either. एक मिनट. So this is the C7. C7 is quite a large one.
Yes, it's quite. Oh, this is very large. So if we want to do C7 cross transfer,
yes.
Where do we take it from?
We got just divisions at the level.
Okay.
I don't do it, but generally that is taken at that level.
So C7 is always medial to the phrenic.
Yeah. C8 T1 would be here. We need to cut that, but then I think the delegate I can feel it. It's just inferior to the.
C8 T1 we don't need to go. Yeah. C7 is the most critical for us. I think that is we have seen.
You can feel here. You can see here C8 T1. You can see here.
Not from our angle.
This one.
Yes, we can see.
You can see here.
Yes, we can see.
Yeah. So this is the lower trunk. You can dissect if you want, but for sake of time, I'm not going there. So this is in short the supraclavicular
dissection.
Exposure. Anything more you want to?
No, I think excellent exposure. Thank you, Dr. Ketan.
Yeah. So then infraclavicular should I do now or afterwards?
So we'll switch to span assessment by Dr. Praveen.
Okay.
Can you show the spinal accessory, or that's Dr. Praveen is going to show?
Praveen, you're doing it, no? वो तो उनका खत्म हो गया ना फिर दिखाते ना
कैमरा सेटअप करिए डॉक्टर प्रवीण, माइक लगा दें डॉक्टर प्रवीण पे।
Deepak, any question?
No, sir, it was a very nice demonstration.
So, about the position, if you see, we had tied the hand, so all the delegates, when they come, keep the arm abducted, little bit of extension, keeping some, say saline bottle under the shoulder.
Right.
And tie the arm so that it is abducted. So it's a rigor mortis patient, so it become very stiff.
Correct,
So
correct.
this way you do it. You can see here.
Thank you, Dr. Ketan. So, Dr. Praveen, we are there with you.
Yeah. Yes, sir. So we are doing the spinal accessory. Am I audible?
Yes, slightly volume increase कर दें Dr. Praveen की. Yes, Dr. Praveen.
Yeah. So we are doing the spinal accessory to suprascapular nerve transfer here.
Right.
And the cadaver, fortunately, what we have is a very fresh one. It almost looks like a very almost as if you are operating in a patient because there is some bleeding from the vessels also.
Right.
And we are not able to control the bleeding. So it is giving a very real
So if you
feel.
can orient us, this is the left side.
Yes, sir. This is the left side of the. What it is showing there? Yeah. This is the left side, and this cross mark is the point which I was mentioning. That is the top point of the acromion.
Right.
And the staggered line here is the clavicle.
Right.
So our incision is a transverse incision 1 inch above and parallel to the clavicle.
Right.
The incision goes almost 1 centimeter behind the marking of the acromion to
Right.
make it easy. And once we have cut the skin and the subcutaneous tissue, we ask our friend to retract on one side and the other one on the other side. And then we see the second point which I was talking about, the sensory nerve. So
Right.
this sensory nerve is coming along with a vein here. So this is the place where we should get our spinal accessory.
Okay.
This is the anterior border of the trapezius. This
Right.
is in line with our marking, and that is the sensory nerve. So that is the place where we should search our spinal accessory nerve. And it will be there in this adipose tissue over the anterior aspect, and once we go in, we should be able to get it quite hopefully. Okay, one retractor on my side. इस तरफ लगाना है, ठीक है?
How deep is it usually in centimeters or any guide?
Yeah, it is quite deep. I think it will be almost 1 inch deep.
Okay.
And you remember Dr. Deepak was asking whether we go more proximally and harvest and how we make sure that we are leaving some branches intact. So you see, I am not going proximally at all. I am in the lower part only. And in that lower part, the nerve would have already supplied the upper trapezius.
Right.
So we need not worry about denervating the whole trapezius. And when I tell it is easy to find only, we will not be able to find.
cutting off fibers of trapezius.
Yeah, and actually this much we should be able to get. I've not heard
Here,
of-
what should be the direction of the nerve?
The nerve should be going in this direction.
Horizontally?
Vertically downwards.
Vertically downward.
Mm. Actually, this is a nice thing only, but we are not able to get.
So ideally, like when we see, we go just
Sir?
below the fat pad and just above the fascia, right?
No,
Muscle.
sir, I yeah, true. So let us go one more go. I will divide this sensory part. Try to go more lower down. Hmm. Yeah, there it is. It is a little deeper than usual, but I think we have got it. Right angle is there?
Yes, we can see.
That is the spinal accessory. I must agree that this is the toughest I have had in this year. And it is year end now. So again we see here, that is the vein which is accompanying the spinal accessory nerve here.
Can you point
And
out the vein, doctor?
is it seen there? These are the two veins going this side. Here, these ones.
Okay, yes.
Yes, which I am holding
Yes,
in the
now
forceps.
we can see. Yes.
So, and here it is vertically going downwards, and we can go in little bit more depth and get a good length of the nerve. So yeah, somebody retract on this side. Yeah. So now this is the place where it is coming out of the anterior border of trapezius. The proximal branches going to the upper part of the trapezius would be at this level.
Right.
So we are not dissecting at that level, we are going in the depth. And again, it is a nice thing, the same what we were discussing, this is the medial head branch,
Right.
the middle trapezius branch. This one.
Right, we can see.
So if we are doing a transfer for musculocutaneous nerve, which is very critical one for us, we would cut here.
Okay.
And sacrifice the middle trapezius. But if we are doing only for the suprascapular, we will go a little bit more lower down. Take the scissor. So I will go a little bit more lower down and get another 2-3 centimeter length of this nerve. So I will cut it as down as possible. It will come up like that nicely, and we have preserved the innervation to the, this is not the branch, the branch is this.
Right. Yes.
So we have preserved the branch. It will appear sometimes as if it will not mobilize well, but if we go little bit more lower down, this will act like our hinge point, and then leave this now. And from there on the direction will change.
Right.
So this much length is quite sufficient. We have, because trapezius is also a secondary stabilizer of the scapula. So if we are able to save the middle trapezius, our shoulder abduction is going to be much comfortable. So it is good to save this for the shoulder. So we get a good length. I have divided it here, but in clinical practice, I think it is not a good thing to divide it, because once you divide, then coming back and finding that nerve becomes difficult. So it is best to divide it when you are ready to repair or do the nerve cooptation. We have to only loop it and keep it there.
Right.
Here we have divided because I have a lot of people helping me in this surgery today. Now we go on to the anterior dissection. We have dissected a bit. We have removed the platysma. And once we remove the platysma and the upper fibers of the sternocleidomastoid, we start seeing this muscle, the omohyoid, as Kedan sir has just now shown. So this is omohyoid. Now here our task is to find out the suprascapular nerve. So as I mentioned, we will cut it near to the neck area and reflect it outwards. This gives us a sense of which place we should search for the suprascapular nerve. Take one mosquito here. Often we can just palpate and feel for the nerve at that level. And we start dissecting in this area. There will be a lot of fatty tissue there. But in that fatty tissue lies the plexus and also the suprascapular nerve.
So you do not reflect the fat pad. We just dissect inside to find that nerve.
Yes, sir. While identifying only dissecting within the fat pad, later on we will raise this fat pad. Now when I dissect the fat pad, within the fat pad itself you will be able to see the nerve. This nerve popping out is the suprascapular nerve. That's the suprascapular nerve.
Right.
So our main identification point is the omohyoid. So it is going in the same direction as omohyoid. Just at the base of the omohyoid you start searching. And here as I was showing, suppose you are concerned about whether this nerve has got some injury, you dissect more towards the clavicle. Some fibers of trapezius we have already removed as we had slight difficulty in finding the spinal accessory. And then you put one retractor here. थोड़ा shoulder को नीचे की तरफ खींचना. And once we do that, we'll be able to go in the depth here. And when I palpate, I'll be able to palpate even the scapula there. Somebody put finger and palpate along the scapula, along the nerve. You see on your pulp, point the pulp towards this side, that is the scapula. Tell yes. Yes. So you got a very obedient friends here, so they are agreeing to whatever I say. But it is truly, it can be easily palpated. We can even feel the notch. Yeah, once you go there, yeah, this side when you put, you'll be able to feel the notch. Lady finger is very sensitive. She could feel the notch, yeah. Actually, if you palpate here, that is the superior border of the scapula. You go more laterally, then you will feel the notch. Nicely it is felt. I think it is better than what I have felt till now. It is good. And you can feel the nerve. So if nerve is injured or there is some neuroma there, you will be able to feel. Anybody wants to feel? Go with the pulp facing superiorly. Medially, you will feel the superior border of scapula. Then you swipe it, then you will feel a nice notch there. Okay? Your head shake is not very convincing. कुछ बताओ यार उसको. Yeah, yes. Yeah. Yeah. is a good man. You will not feel better than this. So all of you better feel. See, this is the place where the notch is there. Yeah, yes, correct. Thoda idhar. Yeah, ye point. चलो बाबा ऐसे करके बाबा या यस आया कुछ you are still not in good position, man. This is the
I think the delegates, Dr. Praveen, can feel it when they are doing the dissection.
correct. This guy here is not at all agreeing. So this is our suprascapular. We can dissect and go a little bit more closer to the upper trunk here. Take a retractor. So we want more length of the suprascapular nerve. So we try to go as proximal as possible here. So we have reached to the plexus now. This what we are seeing now is the posterior division of the upper trunk.
Right.
And that down there is the anterior division of the upper trunk.
Right.
So posterior division here, and that is the anterior division here.
Correct.
Okay, we are not interested in those two things today. So this is our suprascapular nerve. We cut it just next to the place where it has come out of the upper trunk. And we have already seen that our spinal accessory has got a very good length today. And once you have done this, you would see that it is very comfortably reaching to our spinal accessory nerve. In fact, we have a lot of extra length available like this. So when extra length is there, then we should cut the recipient, because the spinal accessory is the functioning nerve. So we should not cut the spinal accessory, rather cut the suprascapular. We have removed almost 1 inch. So that means we will get a recovery of our muscle 1 month earlier. And now the spinal accessory would go and co-opt with the suprascapular nerve. So now we get the microscope inside and put 2 sutures and then put glue. Any background is there? Yeah.
Yes.
Oh, it's kept background ready. Yes. Okay, yeah. Sure, ji.
Nice demonstration, Dr. Praveen.
So we shall switch to intraclavicular exposure by Dr. Ketan Desai, sir.
Please.
Hello.
Yes, Dr. Ketan.
Yeah. So Deepak, so we have just put the incision here. Unfortunately, you know, this dead body is very old, so all the structures are very stiff and fibrous and all, you know, but
Right.
we will manage. So, you know, I have taken a straight incision.
Brightness कम कर दो. हाँ, ठीक है.
Just to orient the our yeah. So, you know, this is the straight incision which I had taken, a little bit curvilinear straight incision. One flap is retracted, the suture is taken to orient the delegates. This is the clavicle.
Right.
This is the pectoralis major.
Right.
I've detached the clavicular attachment of the pectoralis major here.
Right.
You can see here.
Yes.
So this is the pectoral. This is the pectoral fold. The anterior pectoral fold here.
Right.
This is the deltoid muscle.
Correct.
Okay. Now in between these two, I've just dissected out the cephalic vein. You see here. Can see this vein?
Yes. Yes.
So this is the cephalic vein which one needs to identify the deltopectoral groove. You can see here this vein going up. So we can just reflect the vein laterally, and then underneath, it's so stiff that I can't retract it, but we'll manage it. So you can see here few branches of the medial pectoral nerve, which is piercing this is the pectoralis minor muscle.
Right.
And through it, the nerve is coming out, and then now it's going into the pectoralis major.
Correct.
You know, the undersurface of the pectoralis major. So these are the pectoral branch, the medial pectoral branch. The lateral pectoral will come later on. It comes from the lateral cord and goes directly into the pectoralis major. But here this is the medial pectoral branch.
Right.
You know, this is the pectoralis minor, is attached here to the humerus here.
Right.
So the branches are piercing the pectoralis minor and coming up and then coursing like this and going into the pectoralis major.
Right.
So, you know, while doing this infraclavicular, you should identify these branches and preserve it. Otherwise, you will significantly denervate the pectoralis major muscles, especially the major one. So, once you do that, then you can just reflect this major pectoralis major from the deltoid. The groove automatically separates out. Just little bit of fold of the pectoralis major. If you want to go down, you can cut it. Knife again. So I'm just cutting little bit of fold of pectoralis major.
Okay.
And identify the pectoralis minor muscle with the tendon. It's very stiff, but always when you identify it, just put your finger so that, you know, in cases of brachial plexus injury and all, sometimes because of the scarring and all, especially the lateral cord may be stuck underneath the pectoralis minor.
Okay.
So always have this finger inserted to see that it is not stuck, as I am putting here. Yeah, this is the pectoralis minor tendon which is inserting here in the humerus. cut off. So this is the tendon of pectoralis. I have inserted my finger across.
Yes.
And so now, you can see the whole length of the pectoralis minor with
Yes,
the
we can
muscle
see
belly
nicely.
and the tendon here. And we'll cut here. ठीक है. So we'll cut the pectoralis minor tendon as close as, but keep a small sleeve so that we can resuture it. So once you do that, a small portion of the tendon is still left. A knife. Yeah. Karo. So once you do that, you can easily see the brachial plexus here. Okay.
Yes, we can.
Can you see?
Yes, yes, very clearly.
So this is the first structure, which is this is the lateral cord.
Right.
This one.
Right.
Cut. 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 retractor है? So this is the lateral cord. Can you see?
Yes, yes, we can see.
And this is the probably the medial contribution from the medial cord. This one.
Yes, yes.
And this is uniting and forming the median nerve.
Right.
Here.
This.
This one. And this is the musculocutaneous nerve here, which is piercing this coracobrachialis muscle. This one. Here.
Right.
Tape do. Tape. Specimen is really very, old one, so not very ideal to show it, but whatever we can. So this is the musculocutaneous now. This is the median contribution.
Right.
And they are uniting from the median contribution from the medial cord and forming this median now here. So immediately as it come out, it pierces the coracobrachialis muscle. Just dissect some small part. You see here? This is the median now.
Right.
This one. Okay?
Right, we can see that.
So this is the median now. And this is the, musculocutaneous now. This is the median now. Now we'll have to see the posterior cord. You see here, this is the posterior cord.
Yes.
So this is the posterior cord. One minute. This is the retract so that they can see. नहीं इधर वो छोटा retractor डालो. Here. ये निकालो ये और इधर डालो. Posterior cord is the largest one in the cord.
Right.
Sling down. Because it receives contribution from all three posterior divisions. That is why it's large. I have to just go a little bit superiorly now. Scissors do. Medicine. Scissors. इधर रिट्रैक्ट करो. ये रिट्रैक्ट. ये बहुत बड़ा है, ये तो दिखेगा नहीं उनको. छोटा वाला दो. ऐसा करो. We'll try to identify the medial cord. Yes, you can just follow this way, now, the median contribution. This is the medial cord. Artery. Chota artery. Artery. You see here? Hello? Delegate. Hello?
Yes, yes, we are there with you.
Yeah, this is the medial cord.
Right. So we've seen all the three cords.
Yeah. Then one can trace the branches,
So the axillary to
yeah, I'm just showing it.
teres.
काटो इधर ऐसे रिट्रैक्ट करो, ये पकड़ो. So you can see this is the axillary now.
Right, very nicely.
Yes,
yes.
And the other continuity is the radial now. This is the radial now.
Right.
Is the retract करेंगे. Sling दो. So this is the radial now I have tagged.
Right.
And the below is the axillary now.
Right.
एक और sling दो. So axillary now, leaves the posterior cord and runs transversely to enter the quadrangular space. डालो. नहीं मेरे को दो, छोड़ो. निकालो. चलो. So this is the axillary now.
Right.
Okay. So I think this is
very nice demonstration.
Yeah. So as just to summarize the thing, just take a lazy S sort of incision from clavicle down to the mid arm. Identify the pectoralis major and the deltoid muscle. Identify the deltopectoral groove. Identify the vein which we have done here. And then in between, retract the vein laterally, and then split the muscle. To split the pectoralis major, just detach it from the clavicular attachment, and then detach the pectoralis minor once you split the groove, and then cut the tendon as close as the humerus, leaving a sleeve, and underneath would be the brachial plexus. First structure you identify is the lateral cord, and then posterior would be the posterior cord, as we can see here. And then to the two terminal divisions of the posterior cord, the radial and the axillary nerve. And these are the two terminal divisions of the lateral cord, the median contribution and the musculocutaneous. And this will be the underneath the medial cord and the ulnar nerve, and all. You trace a little bit distally, but that you can do it. Okay.
Thank you,
Yeah.
Dr. K.
Thank you, sir. Now we move on to the demonstration of Somsack procedure.
Yes. Surya, how many more after that?
So one more.
Okay.
One more. What is that?
Opening.
Opening. Okay. And take you the forceps. So this is the skin incision over the lower border of the deltoid proximally, and then at the insertion of the deltoid, going to the center of the posterior aspect of the mid-arm.
Okay.
So we have put the incision and raised the soft tissue.
Can you just zoom out so that we can see the position of the hand?
Yeah.
And get the orientation. Okay, so,
So
this is on the left side
position.
only. The hand is
Left
on the
side.
abdomen. Okay.
My hand now is on the top point of the shoulder.
Right.
The arm is placed over the chest.
Right.
So we have got a good exposure onto the posterior aspect of the arm.
Right. Right.
The skin flap is reflected downwards.
Right.
Retractor laga do udhar. Put a cat's paw there. We'll put this one again. So first we identify the lower border of the deltoid, the most posterior aspect of the deltoid.
Correct.
And we retract it. We'll be seeing one nerve coming from the under surface of the deltoid. This is the sensory branch which is coming from the posterior division of the axillary nerve here. Okay. There is a small vessel also along with that.
Yes.
Small vein. This is the nerve. So this is one way of reaching to the axillary nerve, that we can trace this nerve and go down. And since it is coming from the posterior division of the axillary nerve, we can identify the axillary nerve. Actually, this is the posterior division of the axillary nerve. We can identify like this, but we will come more anatomically. First we go down. In the lower part of the dissection, we want to find out the radial nerve and its branches.
Right.
Here, this looks like a single muscle, but one of this is the lateral head and another one is the long head. So we need to find out the interval between two, because radial nerve is in the interval between these two muscles. So there will be a slight color difference between the two, because the long head will appear little bit more palish, the lateral head will appear more reddish, but that is not the case in the cadaver here. But still we can see a slight color difference between the two, this muscle and this muscle.
Right.
And that is the place where you need to dissect and go inside. Moment we put our scissor, it will start appearing, yes, as if like this is the true gap between the two. And then with blunt dissection, suppose you are not able to find the gap, go more proximally. Proximally there is no lateral head. So whatever triceps is present proximally is the long head. And we can come from proximal and then go distally.
Okay.
Eventually reach in the same plane. This is the plane between the long head and the lateral head. So in this plane we will get the radial nerve. So this yellow fatty tissue is having the radial nerve inside. That's the radial nerve and already dividing into its branches. That's the radial nerve.
Right.
So the branch which is lying most superficial here, this division generally would belong to the medial head. And that can be confirmed by doing electrical stimulation. And we should make sure that it is not doing any extension of the wrist or the fingers. Now we try to find the long head branch. Come, madam, here. So we come more proximally, and more proximally we will be able to find this muscle. This muscle transversely lying at this level is the teres major. This muscle is the teres major.
Right.
So lower part of it would be tendinous and the upper part is muscular. So radial nerve disappears under the surface of the teres major. So this is our radial nerve here. The nerve branch which is coming just beyond the trapezius, the teres major, is the long head branch.
Okay.
So we can identify the long head branch at this level, and then we can.
So inferior margin of teres major is the most important landmark.
Teres major as such, because inferior margin will give access to the long head branch,
Right.
and the upper border will give the reference to the axillary nerve.
Right.
Okay, self-retaining one there. Okay. So now we see here, we found that one branch which was more superficial. This probably is the medial head branch. Then we go more proximally. This is our teres major. These are small vessels which will be always crossing across. We can clip them or cauterize them. This is the lower border of teres major. At this level, the long head branch would be coming. Right angle give. And this branch which is coming out is the long head branch. This branch here. Vessel loop is there. Yeah. This is the long head branch. And we can see here it is quite discrete, nice branch, but the length of this branch is not very big. It is maybe around 3 centimeter. So sometimes if you don't have a good length of axillary nerve, you may appear as if you are falling short. So in those cases, other trick is you dissect it till more proximal and divide the lower part of the teres major. So by dividing the lower part of the teres major, you could increase the length of this long head branch by almost 1 inch. So that's the long head branch now, and we already identified the medial head branch. Also here we can see a nice lateral head branch going.
Right.
Okay, so this is not that common to have a very discrete lateral head branch, but here it is there. So we have a choice of using any one of them. Now we take our attention to identify the axillary nerve. Now, as we were discussing before, the teres major is the main landmark here. So the lower border gave us the long head branch, and the upper border will take us to the axillary nerve. I have to divide this. Now somebody retract there, please. इधर से ये मसल लेगा. Very good. Cat's paw, take cat's. So once we take this muscle on one side, we'll be reaching in the quadrangular space. That is the quadrangular space there. And here we will have the axillary nerve and the circumflex vessels. So we need to go slow over here, because if we damage the circumflex vessels, they will ooze a lot. Take a retractor. That's the axillary nerve, this one. Okay, right angle again.
What is the muscle belly seen lateral to it?
This is the long head.
This is the long head.
Yeah. So the quadrangular space, one boundary is the long head, other one is the teres major inferiorly. This is the axillary nerve. Now, as we dissect it down, you will be able to increase the length and reach the main trunk. Now here one of the main confusion is often is which is the anterior part and which is the posterior part.
Right.
So whichever is thicker is the anterior, whichever is thinner is the posterior. That is one way of identifying. The second way of identifying is whichever part of the axillary nerve is closer to the humerus. that is the anterior. So now if we see, this is one part and I am leaving the other part behind there, that is the posterior part. This is the humerus. So whichever side of the axillary nerve is closer to the humerus is the anterior. Whichever is bigger is the anterior. The third thing is we pull the sensory branch and confirm whatever is moving with the sensory branch is the posterior division. So we can see here. So if we pull on the sensory branch which we identified initially, we will find that there is more movement in the posterior division of the axillary nerve. And that's how we can identify the anterior division. We have to go in the very depth and divide it, because we want to reach to the long head branch there, which is almost 1 inch away. So we should go in the depth here and then divide it down there. In case we have a good size of the long head branch, we could attach this transfer to the whole axillary nerve also, but generally it is only the anterior division what the transfer is done to. So I am going more in the depth now. We always clip it in the depth and then cut, so that there is no bleeding after we have cut it. Once you have cut it down, it will come nicely over there. You can get almost 1 inch length of it. And whichever branch you have planned, the long head or the medial head, we cut it as distal as possible, and then the two will join to each other quite comfortably. Any questions, comments?
No, very nice demonstration, Dr. Praveen.
Next, we shall demonstrate the Oberlin procedure. Oh.
हाँ जी, ये वाला
लाइट दिखा देना, लाइट दिखा देना।
उसके लिए जो इन्होंने ट्रेपीजियस मेजर को नीचे रिट्रैक्ट किया था, that is the method. That was the nerve.
वो वाला लाइट दिखा दे। निमेश, get that light here, one of the lights. Manoj. मनोज को बुला, मनोज स्टूल
चलेगा, एक मार्कर पेन लो। चलेगा। So we'll do the Oberlin one. The towel clip लगा दो। Microscope लगेगा। So this is the incision, you know, when you do the Oberlin Oberlin surgery, you have to palpate the bicep belly and just take an incision medial to the bicep belly and slightly more, the lower part of the incision should be slightly more medially, so that ulnar nerve and all exposure, if needed, can be done. So can you see? Hello?
Seminar hall.
Disconnect.
Yes, yes. We are listening.
Okay, thank you.
माइक्रोस्कोप लगाना होगा थोड़ी देर।
पकड़ो, scissors, please. Scissors. Extrude. एक दूसरा एंड पकड़ो। So I have changed the cadaver.
Oh, that's why it's so soft and nice.
Yeah. So that was, very hard. It's as good as you are operating on a patient only. First step is to identify the bicep muscle. Just suture ले लो. Sutures ले लो. दो suture ले लो, stay suture.
Okay.
So this is the bicep belly. Can you see?
Yes, yes, we
Okay,
can see
yeah.
very nicely.
दो stay suture ले. हाँ तो retractor लगा दो. Jesus. So once you identify the bicep belly, just cut the fascia over it.
This
Need
is
to-
right upper limb.
Sorry?
Yes, the delegates are asking, so I just told them right upper limb.
This is the right upper limb. This is the superior aspect. This is
Right.
the inferior aspect.
Right.
This is about 5 centimeter above the elbow joint. Okay.
Right. And standing at the.
I'm standing on the lateral part of the upper limb, outside.
Usually we put a stool and sit it between the.
But
so
the
that is,
height is not getting.
because it is a dependent cadaver, so that's why he's doing.
करो, बैठो. Okay, I'll sit and just see.
So, sir, hi. So, proximal extent of the incision would be how far? I mean, you can extend it as well. When you
No, I think the middle third of the arm would be enough.
Because sometimes it is difficult to identify the musculocutaneous.
No, it's very easy. Here I'm seeing it. If you remain in proper plane, it would be easy to identify artery. 1 minute. So this is the bicep belly. And you can see this is the musculocutaneous now. You see here? Just underneath the belly, there is I've dissected out, but I'm just showing you. This is the musculocutaneous now. This is the median now.
It actually the musculocutaneous pierces the coracobrachialis and then comes and sometimes you have to.
If you not see, then you go high up. Here you can easily see, so there is no need to go.
Okay.
No mosquito don't. Because the anastomosis has to be done at this level. So, if you can find it, then there is no point in going up. I'm very easily, most of the time it's very easily found. So, this is the musculocutaneous now I'm dissecting now. Cut.
So the musculocutaneous usually lies lateral to the median.
Yeah, obviously, yeah. It's underneath the bicep belly here. So this is the musculocutaneous now. Tape.
Yeah.
So I've taken the musculocutaneous. And as you can see here, as you trace distally, this is the bicep branch which is given. This one.
Yeah, we can
Okay,
see.
is entering the muscle. Tape though. Artery lago. So, and this is the continuation of the musculocutaneous now.
Yeah.
String lago.
So the musculocutaneous gives branches to the biceps and the brachialis.
Yeah,
and
so
then
we'll have to
continues.
trace the brachialis branch down.
Okay, and it continues below as
Lateral cutaneous now.
of the forearm. So that will be quite below.
No, it's around 4-5 centimeter below the bicep branch. We'll trace it here. ये पकड़ो. That is entering the brachialis muscle, so it would be going inferiorly. I can see here now. ये छोटा आर्टरी नहीं है क्या, ये बहुत बड़ा है. So you can see here, this is the lateral cutaneous now, which is continuing, and underneath is the brachialis. Brachialis, lateral is up. You see here?
Yeah, we
yes,
can.
very
This is the brachialis branch. Artery लगाओ उसको. And this is the continuation of the remaining part of the musculocutaneous now, that is the cutaneous branch.
Correct.
So this is the brachialis branch which is going, we'll trace it distally to see it's entering the brachialis muscle. You see here? एक पकड़ो,
Yes,
एक मिनट, मैंने
yes, we
retractor
can
जरा
see
लगा था. 1 minute, I'll just adjust the retractor to show you. So just above the humerus, the brachialis muscle is there. So you can see this is the brachialis muscle, and this now is entering the brachialis muscle. Here, you see here?
Yes.
Going down. There are some 2 branches which are coming out, and okay.
Right, Dr. Keth.
Yeah. So the musculocutaneous we have dissected out. Caesar though. Now we'll just identify the median. Median to already we have identified. We'll add the ulnar now.
So the musculocutaneous lies beneath the belly or between the 2 heads?
No, beneath the bicep belly.
Beneath the biceps.
This is the bicep muscle. You can see here, this is the bicep muscle. And underneath the biceps, the musculocutaneous generally lay. Heavy lie over here. Chodo. So we have done that. Now we'll identify the median now. This is median now is easily identifiable. In fact, the first structure when you open the fascia is the median now.
Median now.
Kato. This is the median now.
Yes, yes.
You should dissect the portion of the now only what we want to use it. You should not just go on dissecting it, but it should be adequately mobilized so that during the flexion movement there is no undue stress on the anastomosis. So this is the median now which we have dissected out. And underneath lies the brachial artery, you know. So this is the median now, which is dissected. Underneath lies the brachial artery here. Okay.
Yes, clearly see.
So there, in fact, the median now crosses the brachial artery. First it lies medial and then cross and comes lateral. So reflected there would be a vein, and just medial to that would be the ulnar now. Sometimes ulnar now would be relatively very deep, and you may have to spend some time searching it, but to do it, we cut off. You can palpate it sometime, you can roll the ulnar now underneath your finger and identify it. Efficient cut off. If sometime you don't get the ulnar now, easily, then just trace it in the intermuscular septum, the medial intermuscular septum, and from there on, you can I'm just showing you. Cut off. Cut off. Cut off. One. Cut off. So this is the ulnar now. Okay.
Yes.
So if sometime when you find a little bit difficult, then just go distally and just identify and then come up. Majority of time you don't have any cut off. इधर लगा लो. So in that way, we have dissected all the required nerves in the mid-arm.
Correct.
Thank you, Dr. Ketan, for that nice demonstration.
So you don't need now the so
No.
when in Oberlin, what you do is just for the delegates. This is the bicep branch. So sometimes the biceps may not go right up to the ulnar now. So what you need to do is that you have to do this little bit of internal neurolysis. In that way you can mobilize the nerve.
Correct. So during dissection, they can practice this.
Yeah. So this now, proximally they can mobilize the nerve and then bring it over here near the ulnar now and take one fascicle here and
then
the brachialis is not that difficult because both ulnar, the median and the brachialis are side by side.
Correct.
Okay.
Right.
Thank you. Any
Thank
questions?
you. Thank you. No, I think it was excellent demonstration. Any questions?
So this is basically you do the biceps with the muscular ulnar. This because of the length permits and also the brachialis branch is nearby to the median now. That's the reason we do it.
No, the median has got a lot of supply to the muscles and all. So better use.
We can do it other way around also.
Yeah, we can do it. Sometimes if the one nerve is weak and all, then you can use change the anastomotic options.
Okay.
Any other query?
So we break for lunch.
Dr. Praveen, it is a 5-minute procedure. So I
Right.
will show the outside in and outside in technique devised by the team. The nerves are already cut, so just have to suture it. Microscope hoga, microscope.
So lunch is ready. Whoever wants can start the lunch. Those who know suturing. Otherwise, those rest can sit here and watch. 2 o'clock we will be assembling. All those who are having the hands-on registration can go down to the cadaveric lab.
One more self-retaining is there. Yeah. Forceps forceps. Normal forceps. Forceps, sir.
Surya? Hello, Dr. Surya?
Hello? Yes, sir.
Surya?
Yes, sir.
What about the pronator quadratus and the ECRB?
So we'll discuss it, sir, whether we have it today or like after lunch.
Yeah,
or-
no, our delegates had this.
So if the delegates, it depends on the delegate. If they want a master demonstration today, and after that, hands-on by the-
If time's there, we can do it tomorrow.
Yeah. So it will depend on what they want. Because then they will have limited time for hands-on.
There is a demand from the auditorium.
Okay.
You
If,
have
if
come
it
for
can be
hands-on
shown.
or,
So lunch-wise, I think.
No, we shall have it post-lunch. We'll have, then if the delegates want demonstration
one
of
the
PQCR.
candidate, like one of the cadaver, when other things people are working on it, then they can show it side by side.
So only issue is there'll be crowding here again. That's the issue.
No, it's not possible. I mean, let's just show whatever you want to show.
Yes. Okay.
Microscope is possible. Okay, then let us see.
पोस्ट लंच कर देंगे
Take
कोई
out
बात
my
नहीं
loop, भाई. हाँ, you take. हाँ, ये यहाँ पे पकड़ के यहाँ से पकड़िए.
Okay. Where is the lock of this?
For those who are here for hands-on, I mean, the technique you can see or you can discuss while doing that. Also, you can have a quick lunch and go down. Otherwise, you won't have adequate time for hands-on. Really.
थोड़ा अंदर आने को भैया उसको। कैसे अंदर आने को?
इनसाइड आउट कुछ तो भी स्विचरिंग का नहीं, मतलब उनको बताना काम है यार, वो करेंगे अभी सेट कर। तुम बैठो अभी, अरे हैंड्स ऑन के लिए जा रहे हो भाई, बाकी लोग बैठ जाओ। खाना तो चलता रहेगा, खाना खाने के बाद नीचे हैंड्स ऑन। हाँ ठीक है। हाँ ये ट्रॉमा सेंटर में नहीं चल रहा है। हाँ
ये लॉक हो जाएगा अभी?
हाँ ठीक है।
Cut it here. For micro forceps again. Micro forceps.
अरे रमेश बैठो यार। Yes, Surya.
So this is the bite what I am taken in the epineural tissue.
Okay.
And we can see, I don't know whether microscope picture is seen there. This is
We are seeing it, but I mean it is like not very much clear. Can you focus a bit? Centering also needed.
Is it better now?
No, it's not center. It's on the upper part. Yeah, now it's quite okay. Yeah, perfect. Now it's okay. Still, you can center it in the middle. It is in the upper half. It is not properly seen.
Put one hand here. Yeah. Is it better now?
No.
Ah.
Yeah, it looks.
Ah, okay.
When you are, yeah. Yeah, this images looks okay.
Okay.
Yeah, perfect.
Perfect.
Now how I go to this microscope? No, it is okay. It is
Yeah, it's perfect now. Yeah.
adjustable only. So we can see over here that is the spinal accessory nerve.
Yes.
And nice nerve part and the non-neural part.
Yes, sir.
So I've taken bite in the non-neural tissue, not having anything of the neural tissue there.
Okay.
And I've taken a normal bite there. And now we will turn the needle and go outside in again in a reverse manner.
Mm-hmm.
Again in that non-neural tissue, not taking any of the neural component. Okay, once you take this outside in bites, so as I told, usually 2 sutures is sufficient. So once we are throwing the knot, the nerves come in good opposition. We don't have to suture it very tight. We just have to oppose them and bring them close to each other.
Okay.
Here like that. Any other needle holder is there? Huh?
So what is the advantage over from outside in and inside out?
Yes, sir. So when we are doing a nerve repair, basic suture cutting. So basically, we don't want any
Neural tissue
non-neural tissue to go between the nerve, and we
Okay.
don't want any neural tissue to outpouch.
Okay.
So if we are taking bite only in the non-neural tissue and closing it, taking a bite as if like you are doing a figure of 8 suture,
Yes.
then it entangles the non-neural tissue outside and pushes the neural tissue inside.
Yeah, got it. Very nicely done.
So it approximates the non-neural tissue and doesn't allow the approximates the neural tissue and doesn't allow the non-neural tissue to go inside. So that is the basic aim of this site type of repair.
Yes.
I have to do it again, looks like. Is it seen well here? There, here it is not that well. I should see the monitor and do, huh?
Yes.
Is it okay still there? Now it is better for me here.
Better, no?
There it is okay. Okay, suture cutting. One more forceps is there. Forceps. So once I put the sutures on both sides, now we align it perfectly like that.
Yeah, it looks nice.
So you could opt to put one suture here, which will totally circumferentially close it well. If we don't want to put suture, or if we have glue, then there is no further suture required. We just put 2 drops of glue here, it is done.
Yes, sir.
So these sutures are going to give the stability and we get a good opposition.
Yeah,
So
it's
you
looking
see,
very
nice,
nice.
nice thing is there is no non-neural tissue inside and there is no nerve popping out. So that is
Yes.
the main advantage of
Yes, sir. Very nice, sir. Thank you very much, sir.
Thank you, sir.
Very nice
Very nice
demonstration.
Thank you, sir.
Abhishek. चले जी देख के भाई भाई लूप इज देयर ना ओके ना ओके जी हाँ जी ये ले लीजिए भैया